All right, so we're recording now. Hi, I'm Melanie Mosley. I'm one of the graduate assistants for TexCHIP. I'm a third-year doctoral candidate in our counselor education and supervision program. And I'm excited to see everybody and hope we get some good training today.
Hi, everyone. I'm Ashley Burks. I'm also a doctoral candidate here at TAMU-CC. I'll be running all the stuff in the background, so let's have a good session.
All right, so the first thing that we're going to do today, like Dr. I had mentioned, is that we are going to have our panel discussion. And so for those of you that have been with us for a little while, I'll read the case study, and then we have some just kind of a little bit more broader questions, and then we have questions that our students actually submitted. But first, I wanted to introduce our panelists. So we have Grace and Crystal. They're both counselors at Synacor. And so if each of y'all wanted to kind of introduce yourselves a little bit more.
Sure, I can go first, Melanie. So my name is Grace Welpley. I'm the clinical manager at Synacor Foundation. I'm a licensed professional counselor and a licensed chemical dependency counselor, and I've been with the foundation for 6 years. So I'm so excited and honored to meet everyone and get to discuss the case.
Thanks, Grace.
You're welcome.
Hi. Thank you for having me. My name is Crystal Aguilar. I'm the facility director at Synacor Corpus Christi. I've been with the foundation for about 6 years. And in addition to being the facility director, I'm an LCDC, a licensed chemical dependency counselor as well.
Awesome. And again, thank you both so much for agreeing to serve as our panelists for today. So what I'm going to do is I'm going to go ahead and share my screen just so that way we can all see the case study, but I'm also going to be reading it out loud just so we all kind of read at different speeds. So that way we're all on the same page. All right, can everybody see all my virtual people? Can y'all see it? See my screen? All right, awesome. All right, so Kai is a 13-year-old third generation Asian American who just completed his first year of high school. Kai's family originates from Thailand, and they often celebrate their heritage through holidays, family events, and food. But Kai and his parents are mostly acculturated to living in the United States. Kai's parents hold high expectations of him, and he often finds himself falling into the model minority myth. Kai shares with you that his parents expect him to make good choices, do well in school, have morally upstanding friends, and generally be a perfect child. He also shares that he feels like he can never measure up to the high standards of his parents, which makes him feel guilty and like he is failing them in some way. Kai jokes that his mom is the face of the Tiger Mom movement and states that she can sometimes be over-involved in his life because of her desire for him to do well. As you talk with Kai, you learn that he skipped 8th grade, which is why he just finished his freshman year. He mentions he didn't know if he was going to finish and that it's been a big adjustment. Despite the age gap between Kai and his peers, Kai shares that he's beginning to make some friends, and he feels like he's been accepted into a friend group that really accepts him for who he is. He shares that he doesn't feel pressured to fit in, and he believes his new friends would be there for him through thick and thin. In separate interviews with Kai's parents, his mother shares that Kai has been acting a bit unusual for several months. She mentions that Kai is usually very energetic, talkative, friendly, and outgoing. Lately, she has noticed that Kai has been more reserved at home, a bit moody, and seems troubled in some way, but she can't quite put a finger on it. She also shares that Kai's grades have fallen since beginning 9th grade, and getting Kai a tutor did not seem to help. As Kai's father confirms these observations and adds that Kai hasn't been as open with him as he usually is when talking about his friends and after-school activities. Kai's mother shares that at first, she thought Kai's behavior might be a normal response to skipping a grade, going to a new school, and dealing with puberty, but now she is concerned that something else may be going on. When you ask Kai about his parents' concerns about his unusual behavior, he seems reluctant to answer your questions, but finally gives in. You learn that Kai's new friend group is actually a group of sophomores who have been known to have a bad reputation because of rumors that they are drug users. Kai admits he began huffing with his new group of friends because he wanted to fit in, but now he has started huffing even when he is not around his friends. You learn that Kai initially started huffing permanent markers with his friends and gradually experimented with the paint in his father's garage. Kai states he got more experience and began bagging so that he could bring substances with him to school. You also ask Kai, or you ask Kai how often he used to huff with his friends when he first met them, to which he replies, only for a little while after school. I didn't want my parents to find out, so I didn't spend a lot of time with them. Initially, Kai would huff whatever his friends shared with him to socialize with them, but soon it began helping him deal with the immense pressure of his parents and difficult coursework. Now Kai says he bags throughout the day at school by asking teachers to use the restroom during passing periods. Kai shares he feels like keeping up this behavior is a chore, and he really doesn't want to be a bad kid in his parents' eyes. But if he goes too long without huffing or bagging, he starts to feel the craving. You ask Kai if his substance use is part of the reason why his grades slip, and he shares it's hard to really care about anything except when I can escape again. So our first question is just, what is the difference between bagging and huffing?
Do you want me to jump in, Melanie? Can I jump in?
Sure, yeah.
Okay,
whoever
perfect.
wants to go.
So with huffing, and this is just such a common problem because it's so easily accessible at, paint stores, supply stores, Walmart. The reason why people, want to huff paint, aerosol cans, whatever, is because it gives an immediate rush of euphoria. And it can later cause delusions and hallucinations, but it is an escape from a person's current life, right? It's a really unhealthy coping skill to attach from any type of emotional pain, which it sounds like Kai is doing. And with bagging, there's a little bit of a difference there. I actually, like, this term, I don't hear a lot. Like, I don't hear bagging a lot. In the 6 years of chemical dependency counseling, I don't think I've ever heard the term bagging, but I know we all know huffing, right? But that's kind of the, why people use and like why they go to like this method of use, because it goes directly into the brain immediately, because it's usually with like nasal inhalation. It goes directly into the brain. It's very quick. It's very immediate, which goes into the instant gratification of being able to detach in this way. But with bagging, that's really not a phrase I've really heard before. And this is such a great case, because we always hear of these terms that I remember, like, the first time I started thinking like getting into drug abuse, I didn't really know what ice meant. Like, I thought it was like, is it meth? Is it cocaine? Like, what is ice? And like all these keywords that we find in substance use. And no day is ever the same, because there's so many different terms to use. So I guess my question for everyone is, like, what context is bagging exactly? Because there's just so many different ways to use this term, I guess. So I kind of wanted to open it up to I can't really see all the students there, but what did they think it means first?
So did y'all hear her? What do y'all think bagging means?
I'd imagine bagging is where you either paint or something inside the bag and you carry it with you, so then inhale at a later date or a later time period.
Okay, thank you, Travis. Is that what you found? Yeah. Yeah. Okay, nice. So some of our students Googled it, right? And
what does Google say?
Travis was right. It's, they either spray it or, pour it into a bag so they can, inhale it whenever they want, pretty much.
Right. Easily accessible, right? And with the case of Kai, he mentions it in the case study, it says, he's waiting for the next escape, right? He's having all those cravings. And it's so easily accessible. This is just such a common thing with adolescents, because it's just so easily accessible. And you can find it in your parents' garage, which in the case that he says, hey, he went to the garage, his dad's paint, right? Anything with those types of toxins, and it can give those, hallucinations and everything. So it's another way to make it really easy accessible.
Awesome. Thank you, Grace. Crystal, was there anything that you wanted to add?
I'll just, piggyback off what Grace said. I knew what bagging was for huffing. It's a little bit more, it's inconspicuous to kind of get a little brown bag or something and kind of fold it up, spray some paint in there and fold it up and stick it in his backpack or his pocket. versus walk around with, you know, a whippet can or the air thing that, you know, that they have to hold to their mouth and kind of inhale it. So it's a little bit more inconspicuous to have the paper bag. It could be very, very small. So bagging, I guess, is a term that we don't frequently hear in our line of work. But in his situation, he knew that at school, you know, having a bag with him is something that he would get away with. No one's really going to question, right? Because you need a bag for various things. He could have snacks, he could have all kinds of things. Whereas adults, they just full on, you know, they don't care. They'll walk around with the aerosol itself. So that's it.
All right, awesome. Thank you. So our next question, what's your clinical impression of this client and what would your first steps be in assisting the client? So just whoever wants to jump in first.
I can go first because I love this. I love it. This is such a good case. So for me, and one of the things I love about TexCHIP is the integrative approach, right? So we want to look at the entire person as they are, all of their needs. And for me, there's such a big multicultural aspect to Kai. And I know everyone in the group has or is going to be taking multicultural counseling, right? So that's a really important component here because of the, you know, Asian pressure of a perfectionism, right? And those family values, right? Kai is verbalizing in his case study that he has a lot of pressure, he needs to do well. And so my first clinical impression of him and the first steps to assisting him would be to kind of figure out what feelings or what he is trying to self-medicate. It appears it could be anxiety. He might have some anxiety symptoms going on. So I might want to ask him, you know, what does anxiety feel like for you? You know, what are some of those physical symptoms? Why do you feel the need to escape from your current life? What's good and what's not so good about your life? And having him really separate those things so he can figure out himself, you know, why he is medicating to change the way he feels. Because with substance use disorders, that's the primary component. People are trying to change the way they feel or to add feelings in. Sometimes people feel really numb and they want to use or drink to add feelings. Sometimes they're trying to self-medicate numbness. But for Kai, it sounds like there's some anxiety going on. I want to kind of talk about, you know, what depression feels like for him, because he's definitely self-medicating something, which is why he's decided to start coping in an unhealthy way. So that's kind of where I'd start with him.
Okay, awesome, thank you. Crystal, anything? Yeah.
Yes, I'd also want to add, so in assisting Kai, it's a two-parter, right? Because he's underage. So it's to also see where the parent stands, to where the mother stands, or both parents, and also how we can assist them. So it's the two-parter because I come from the facility director role, but also from the LCDC role. And it's the reason why I still have my license, to be able to make, to distinguish and be able to have those conversations. What can we do for you? But also be able to ask, you know, how much are you using? And obviously it's a given, right, within this case study. But if it wasn't, it's asking, you know, how much are you using every single day? And then having him be honest, because sometimes the most difficult part is them being honest with their use. And if they're not honest, then, for example, we have a youth outpatient. So obviously, if he wasn't honest, we would put him in the wrong level of care. But if he was, and the parent knew, and we got the appropriate feedback, we would refer him to our treatment center in Houston, which is Odyssey House, which treats adolescents, and it's an inpatient. So that would be, and then, you know, getting all the logistics surrounding that, and then of course, always aftercare, you know, because we always want to treat that full continuum of care so that hopefully this doesn't happen again, and he can stay engaged with services. Because it sounds like there's more components, as Grace discussed, you know, with the depression and things like that, which he would address while he was in treatment, but sounds like there's other things that need to be followed up on after treatment and during treatment.
Great, and yeah, I think it was really cool that you were able to give us like a perspective different than like just being like the LCDC. So it's really interesting. So what protective and risk factors did you notice with this client?
So for the protective factors, in the case study, it says right there that Kai doesn't want to be a bad kid, right? And with our clients, we want to play on their strengths because our clients are going to come in and have just so many beautiful strengths. We want to play on those, that he doesn't want to be a bad kid. He has so much family value, right? He values his family. He values, what his parents think of him. He also wants to be socially accepted by his friends. In the case that it mentions that, his friends that he has that are a little bit older than him have his back no matter what. So he really values loyalty, the camaraderie he wants to be a part of. And those are all beautiful things, especially when he says, I don't want to be a bad kid. So there's a lot of motivation to change there. We just have to figure out whose expectations is he trying to meet? Is he trying to meet his own, or is he trying to meet the expectations that his family has set for him? And really picking that apart. So he's got a lot of strengths here. For risk factors, he's got some risks. We need to be able to dig deep into what's going on emotionally for him, how his regulation is. It's really apparent that he needs some coping skills because his emotional regulation isn't the best because he's coping in a really unhealthy way. So that's definitely a risk factor for Kai, as well as the grades are slipping and he's losing that motivation. He's not able to kind of get himself out of that stuck point.
Crystal, was there anything that you wanted to add?
With the protective factors, I was gonna say the same thing. He makes that real bold statement. I don't want to be a bad kid. But with the risk factors, something that we see commonly with adolescents and adults too, but more commonly with adolescents, is he appears to be a follower. You can identify leaders and followers very young. Those who kind of go with the flow of whatever's trending. What's the hot new drug? What's everybody wearing? What's everybody doing? I want to do that. And then those who kind of initiate everything. And Kai, unfortunately, appears to be the follower because of what's going on in his home or what's going on in his life. And so that was a big risk factor that stuck out to me in the case study, because he started doing this stuff with his friend, and then he did go off on his own. He did branch out, but the fact that he kind of just went off and kind of followed, and the inhalants or the huffing was just what was it, is what he kind of got stuck to, and now here we are.
So then as your role as like the counselor, how would you work on that with him? So that seems to be more of like a characteristic, right? Being a follower versus a leader.
Probably well, for me, it would just be, some autonomy, some decision making, what can you do, or how could you have did that? How could you have did that better? Let's talk about this, and how would you have did that? If you could go back and make this decision, how would you have did that? And kind of let's, and not, instead of a going with the flow approach, let's go back and rethink those decisions. And how would you have approached it differently?
Great, thank you. So regarding your professional expertise, what treatment approach might you use to assist him?
So for me, really with substance use disorders and a lot of other disorders, cognitive behavioral therapy is evidence-based. It's proven to work really well with the population that we work with. And I know everyone knows what CBT is, about attitudes and beliefs and making sure that they're congruent. But especially with Kai, it's important that we help Kai figure out who he is, right? Figure out what's not congruent, his attitudes, his beliefs, his values, and then we look at the behavior and if they match or not. And more oftentimes than not, they don't. Crystal and I see clients every day who have all these beautiful strengths about them and so much support, but their actions and their behaviors and how they view themselves and their perception is so skewed that they're not able to see the situation full circle. So as a counselor, it's the counselor's duty to be able to say, okay, this is your life, right? We map everything out, feelings, coping skills, lack of coping skills, and we let them, we try to get them to see things from a different perspective and get their attitudes and beliefs to match their behaviors. right? And we gauge that stage of change. How likely are they to want to change their behaviors to match those values? And a lot of times we have to really go through that internal conflict that's happening, because more oftentimes not, even with Kai, he's going against his personal values. He has an internal conflict. He wants to be a good kid. He wants to make good grades. He wants to make his family proud, right? Because family and there's a lot of honor there with family values, especially with the Eastern Asian culture. There's like so much family value there. And to dishonor your family is to dishonor yourself. So there's a lot of expectation there and a lot of pressure. So we really have to start to pick apart Kai and who is he? Having him say, who are you? What are your strengths? What are your weaknesses? What are some things you've done to match those things? Who do you want to be? Asking those open-ended questions and letting Kai decide for himself, because more oftentimes than not, our clients have a lot of the answers themselves. They just need some help guiding through the mess to find it. Most of the time, our clients, they are so resilient. They have all the information that we need, right? Even if they're poor historians, right? They have all the information we need, and it's the therapist's job to help them sort everything out and put everything in a way that they can understand and really look at those perception issues.
Crystal, was there a different approach that maybe you use or anything you wanted to piggyback off of?
I do, well, CBT is a big one that we use. It is a great approach, but also like for myself, in my professional role, if I was to get a client in speaking with them, of course, an LCDC is very limited with our boundary, our lane. So in speaking with Kai, for example, if I was his clinician, or in deciphering, what treatment modality or how to approach him best, and he was to disclose, there was maybe some depression or signs or symptoms of any type of mental health, or any indications, then in our facility, we have what's considered, it's COPS-D. It's, Grace, what is the acronym, the name? It's a really long name.
Co-occurring psychiatric symptoms and disorders.
Yes. And it's basically individuals who come in that have substance abuse and mental health. And so what I would do is give him an immediate referral, and that's in-house. And just to give an example, in our facility, it's not adolescent, but all the facilities have it. He would get an immediate referral to start seeing Grace. Because with my licensure is limited. And of course, ethically, I can't cross that boundary. I can get the information, how do you feel? Oh, I feel sad, I feel depressed, and these are my reasons why, and I can obtain that information. And then I can just give him a referral and pass it along so his needs are met. So I can just meet his needs and help him where he's at.
Awesome, thank you. And I know we've kind of already touched in most of these questions, what other information would be useful to know. But is there anything else that maybe we haven't discussed that would be useful to know for Kai? And then are there any potential assessments that you might give him?
Crystal, you took the words right out of my mouth. So that's one of the things that Crystal and I love about Synacor and having that integrative approach is that we have, LCDCs, LPCs, LPC associates. We have a registered nurse. We have a medical director. We're able to treat the client holistically as a whole person, and it's almost like a one-stop shop, if you will. So we get to really look at the client at face value and all their needs. So whenever a client comes into Synacor, they go through a biopsychosocial social. And it's an assessment. And basically what that is it targets a person's life, family, medical, mental health, legal, discharge planning. Anything flagged on the assessment tells the counselor what to put on the treatment plan, right? All the needs that need to be addressed, whether or not they'll be treated, case managed, or withdrawn. And for me, whenever I get a client such as Kai, the first thing I would do is I do a mental health evaluation. I want to potentially administer like a generalized anxiety disorder assessment, or I want to do a PHQ-9 for depression. Those are two of my favorites because they're so user-friendly. The clients it's easy for the client to give me the information. One thing I've learned is we'll have all these really fancy assessments, but it's really important that we match our language to the client. we don't have to use these huge words while we're giving an assessment. It needs to be in a way that the client can understand so they can give us the best information, because the client has all the information that we need. It's just our job to piece it together. So those are the two that I would administer first. I'd also do some, suicidal ideation. I kind of pick Kai's brain a little bit about, what his, history is for, any kind of suicidal thoughts, depression. I'd want to know if there was any attempts before. With adolescents, suicide is very serious. And I want to know if he's had any kind of history or any kind of thoughts of suicide.
Very nice. And then go ahead and do your karate bow.
Sorry, we're getting some feedback. Give us just one second.
Make sure you walk, please.
Well, I think it's our main one. Yeah. All right, there we go. We got it. We're good. Sorry about that, Grace. All right, we're good. We figured it out.
Okay.
Yeah, sorry about that.
It's okay. I think I said everything I needed to, but I wasn't sure if there was any questions or any
Any other, any additional questions over what Grace has already covered for us? Okay, awesome. So we can keep on going. Well, we've already kind of covered this as well, because I know Grace had mentioned, the beauty of Synacor is being able to treat the client holistically. But what would your individual roles be, roles and responsibilities be as part of an integrated care team for Kai?
So for me, and it definitely sounds like he's got some, anxiety going on. From that approach, it would be, making sure that we're addressing both, right? So in our facility, we have licensed chemical dependency counselors. And as the clinical manager, what I do is when a client comes in, I assign them to a counselor and they work on chemical dependency. And then we have like a two-parter, being able to treat the mental health if there's any, beside each other, right, together. So my role and my responsibility for the client is to make sure that we're really digging deep. And it's like a dandelion, right? They're really pretty flowers, but really they're weeds, right? But they're really, really pretty. And to get to the root of the problem, we can't just chop the dandelion out at the top. We have to pull it completely from the root to get to those real issues. So really dissecting what those issues look like for Kai, what feelings he's self-medicating, what pressures are in place to where he feels the need to self-medicate, and helping Kai figure out who he is. And then a licensed chemical dependency counselor would really work on like cravings, triggers, and coping skills for the substance use. But really treating them together is going to be the most important responsibility that we have, because we can't just ignore mental health and we can't just ignore the substance use. We have to treat them both.
So Crystal, what about you? What about within your role? What would that look like?
Excuse me. My role would be identifying, where Kai's needs would be best met. Obviously, we only have one adolescent facility, so he would go there. And seeing, like I said, seeing if the parents were open to him receiving treatment. Again, it's pretty apparent with his use given in the case study that he needs inpatient treatment. But I need to point out something really important, that with the parents in receiving feedback and data and just knowing what I know, and speaking with the director from the adolescent facility, with parents, it's very difficult because it's a couple things. They either say, my child has a problem, here you go, fix it. That's the mentality. Or they don't want to acknowledge that their child has a problem. It was just a little bit of pot. It was just vaping with CBD with THC. They're doing it in my house. It's not a problem. They don't have a drug problem. And so when their attitude is the latter, it makes it very difficult. And then before you know it, the child is a client in our adult facility because things were left untreated. lots of things were left untreated. And I will let you know that a lot of the times the attitude is the latter. And I don't know if it's, and it probably is that there's some shame with putting your child who's under the age of 18 in an inpatient treatment facility surrounding that, you know, because you do, from different areas, you do have to drive your child there and drop them off. And I don't know that there's probably some shame surrounding that. However, there's also positives, right? You're hitting it right before it escalates. You know, if it starts with, you know, marijuana, you're hitting it before it escalates to something more worse, you know, maybe heroin or something like that. But the parents do have a big say because they have to sign the consents, and we really can't start treatment until the parents are on board. So it's kind of a little dance that we have to do. And so my role is engaging in that dance with the parents and saying, okay, this is what we're doing. This is what we can do for you. How about you allow us? And then we go from there. You know, we can have periodic check-ins with you, let you know the status of your child, and, you know, keep you in the loop of their progress. You're welcome to come visit during visitation to see the progress as well. Speak with the counselor, for example, if Grace was the clinician, to get updated with the progress as well. But it's difficult at times. That would be my role. You know, just helping the parents put the child in the best level of care that would meet their needs.
Yeah, and I know, like, from just my own personal experience working with you know, the amount of kiddos that I work with, the hardest part about working with kids a lot of the time is working with the parents too. Because there's always like that fine line of because, you know, as a parent myself, like, yeah, I would want to know what's going on with my child, and at the same time, you know, having to you know, set those boundaries with parents of like we'll let you know what you need to know kind of thing.
Yes.
So what outside resources might you recommend for Kai and for his family as well?
So I think the really important part here is making sure that there's education provided for both Kai and for his family about what a substance use disorder looks like, what are some of the, you know, factors that play into what's going on with Kai. Education is so important because there's just such a negative stigma at times to both mental health and substance use disorders. Substance use disorders more so. So education is going to be a really, really strong component here. So anything that's evidence-based, you know, give Kai's parents, you know, some reading material to read on like emotional regulation and why adolescents, you know, what they're escaping from, why they, you know, self-medicating, giving some information on self-medicating, what they're self-medicating, just a lot of education at first so that both Kai and his family are educated on what could possibly be happening so they can better understand for themselves so that they can kind of come together as a family.
Anything else you'd like to add, Crystal?
To piggyback off of what Grace said, you know, education is big, so they can understand truly, you know, substance use and mental health, because again, there's that stigma. But also maybe Al-Anon, which is for the families of those who use, so they can go and understand that as well. That's a big one. Granted, there's a lot of times that the families or the close, you know, the friends and families don't attend, but it's still a big referral that we like to give. Al-Anon is a big one.
Awesome, thank you.
Yeah.
So as therapists who may not be immersed in the ever-changing world of substance use, how would we stay up to date about the lingo of substance use, slangs that maybe the clients use, and how the drug use changes over time?
So I learn most of how the slang, the changes, I learn through my clients. And they are more than happy to educate me on some of the things that change, right? Like I mentioned before, when I first started in the substance use field, I thought I didn't know if ice was cocaine or methamphetamine. And I quickly had a very fast education on what those things are called. My clients will tell me. And as a therapist and as a student, it doesn't really matter if you have a license or not. It's important that we understand that our clients teach us just like we're teaching them, and they can educate us in ways that we may not get exposure to. We learn a lot from our clients, and our clients, especially with, the population that Crystal and I work with, they have no problem telling us what things are called. I remember the first time I heard what synthetic marijuana was. I knew synthetic marijuana was synthetic marijuana. I had no idea it was called spice or K2. My clients educated me on those two slang words, and they do change over time. But I think a lot of them stay pretty consistent, but they'll always add new words. So for me, reading, doing, evidence-based research articles, CEUs, on education on substance use disorders, they're really good at mapping out, some of the current like slang for substances and how they change. But primarily my clients are the ones that educate me on the changes of what things are called, because they'll say, oh, I was using this. And I'm like, what is that? Can you tell me what that is? And they'll explain it to me. And you're getting it from a first source. You're getting it from a primary source, someone who uses it, someone who's, who knows what it is, and they get to explain it to me. And that's kind of how I learned the changes in what things are called.
And Crystal, how about you? How do you stay up to date with the ever-changing substance use world?
For me, it's a combination of both. Grace and I play different roles. So Grace hears it from the clients because she has more client contact than I do. And because I'm operations, I get the information from the individuals that I speak to on a day-to-day basis. For example, law enforcement. I also talk to individuals from the FBI, and they let me know, what's going on, and they let me know where it's coming from. It's also a big part of my job. Not only do I feel like I should stay up to date, I need to stay up to date, because it is changing. I need to know what's coming over the border into Corpus Christi. I need to know what's coming from the surrounding cities, because that all impacts not just Synacor, but that impacts Corpus Christi as well. But because it impacts Synacor. So every, like for example, fentanyl, fentanyl is big right now, and it's coming in all forms or fashions. So I partner with several people who get statistics from us as far as what we see, and then they share information from them. So, I speak with district attorneys and, the court systems. And so we basically share information. And so that's how I stay up to date with what's going on. And it's a big part of my job. It's what I do. I think every day I'm in a meeting about something. And so they'll say like, what are you seeing down there? And I'm like, this is what I'm seeing. What are you seeing over there? And so that's how we exchange information.
Awesome. So our last question is, there seems to be an element of attachment theory at play in this case, with wanting to belong to a community. And so what substance abuse resources would you direct me to work in this area? So like us as like the students.
So for Kai, and it says it in the case study that he wants to feel a part of, and he's having some type of internal conflict with his family because he wants to make them proud and he wants to do really well by those family values that are put in place. But he's having some attachment issues to want to make them proud, because it goes back to attitudes and beliefs and behavior, right? I want to make my family proud, however I'm doing this, and there's that conflict, right, with Kai. So he wants to attach to something, and in the case study it says that I'm not sure the exact words, but he is attached to his sophomore friends. Right, he thinks that they are going to be there for him no matter what, and they might actually be there for him no matter what. We don't know, and that could be completely true. But he's attaching that type of value to himself. Like if these people are my friends and we do these things together, it's a bonding experience. So if I don't do these things, they'll leave me. So there's a lot of abandonment happening. We really have to process where that comes from. And it, more oftentimes than not, it comes from childhood, from the ages of 0 to 11, developmentally, everything is learned or observed. So we really have to dig deep into, where he got that attachment issue and where it stems from. And so with the community and giving him resources, I know Crystal mentioned Al-Anon. just any type of, like any type of extra activities he could do, group stuff. Obviously, Kai likes to be a part of, so anything group would be good. I know we've got a lot of referral partners that we work with. We work with Coastal Bend Wellness Foundation. We work with Purple Door. We work with Turning Point. We work with, a couple others, AA and NA, sober living houses in the area. We just have so many, everyone's just so intertwined in this community. We're just all very tight knit. And so we get to refer in and out within each other. I know Crystal mentioned it before, we work with MHID, with, making sure the clients get the care and holistic, wellness with MHID as well. So with Corpus specifically, there's so many ways we could go with Kai, but support groups is going to be the number one thing, a way to get him into a healthy environment with healthy people. Even in treatment, there's magic that happens when people are in treatment together that have the same issues. There's this unifying component that he's not alone, that this is not, it's important that we normalize this, that he's not the only one that struggles with these feelings. He's not the only one that self-medicates these feelings. And it's very normal to do so, but it's about challenging himself to cope in a healthy way. But there's a lot of magic that happens when you're in a room with people who struggle with the same things that you do, and you don't feel so alone. And that's the primary component that I'm seeing with Kai, is that he doesn't want to feel alone in his issues. He's just reaching out to the wrong people.
Anything else you'd like to add, Crystal?
No, Grace mentioned it. I mean, Grace mentioned it all, but really it's the recovery community here in the Coastal Bend is huge. So that would, if we really had an individual like Kai, he'd be very fortunate. And it's identifying, where exactly he would like to go. Does he want to work the steps? Is that the type of group he'd want to go with? Does he want to go to a group that's more faith-based, and go that approach? And really he has options. And then when he decided, and when we got his feedback, then we would kind of veer him towards that group. And then, like Grace said, he would be able to see, oh, well, look at all these people. Look at all these people that are just like me, going through the same things that I'm going through. They get it. They understand. And look at all the fun that they're having, and they're doing it sober. They're working through their problems without having to, bag or huff or use anything. They're talking it through. They're using each other. They're using a coping skill of, maybe going and running and exercising or something like that. And he'll get to see that. But there's so many options for him. It would just be really whatever he decided he wanted to do, and then get him to engage.
Perfect. And thank you both so much. And so since we have a little bit of extra time, I wanted to open it up either to our students or to the community members. Is there anything else that y'all want to ask that maybe we didn't get to? Julie, go ahead. So we have a question up here. Mm-hmm. So they asked, how does a person get sent to Centacor?
Crystal, do you want to answer that one, or do you want me to do it?
I got it. So it's different ways. So people can be mandated. We have a contract with federal probation. And so those individuals get mandated to come to our treatment facility. And those people, they're mandated, so they either come straight out of incarceration, or they're on federal probation and they either failed a UA or they did something that is sending them back to our facility, and drugs were involved. And this also could be that they were drug traffickers as well. Not so much the users, but they were involved with trafficking drugs. We have people that just show up because they decide that they're at that point in their life where they need help. So it's voluntarily, and it's also that they get mandated. Short answer to your question.
Thank you. Oh, yeah. So she was talking, or she's asking, so, with a lot of facilities, whenever the client or the patient comes in, they get presented with, here's how much it's gonna cost for you to get treated. So do y'all have something like that? And or who kind of picks up that bill if the client's not able to?
Kristen, you want me to go? Or you?
Yeah, you can take it.
Okay. So one of the amazing things about Synacor is, and Crystal mentioned it before, we take so many contracts, but we also have DISH funding. Right now, we can hold anywhere from 26 DISH clients. And what that means is that the state of Texas picks up that bill. We get the honor to serve the indigent population. We get the honor to serve people that maybe they got terminated from their job because substance use got in the way of their quality of life, right? Maybe they got terminated, don't have insurance. Right now, specifically, we have a lot of funding from that, but year round, we normally have about 20 spots in our facility that is strictly DISH funding, where the state of Texas actually picks up that bill if a client doesn't have insurance or the means to seek resources. One of the things that Chris and I love about Synacor is that we try really hard to remove barriers to treatment, and that includes mental health. There are times when a client will come in and some other place say, hey, we can't take you because of this mental health, and there's all these components that are going to get in the way of you participating. Crystal and I try really, really hard to make sure that we remove those barriers to treatment. We want to work with the client. And I know with COVID being such a huge factor the past couple of years, there were some facilities that said, hey, you need a negative COVID test before you can come into treatment. That was a big barrier placed on our clients because some of our clients don't have the means to get a COVID test, don't have insurance to go to a doctor to get a test. Synacor never did that. We did a screening, we did COVID test in-house. We were able to really provide that type of care and support during a time when, if we're being honest, at the time, even now, our clients were more likely to die of an opiate overdose than they were from COVID. We never shut our doors, which we were very, very, very proud to be able to do that. So it's all about removing those barriers so that a client can come into treatment and seek services, even if they don't have the funds or the insurance to do so.
And then too, real quick, we had an individual who did not have the means to pay. He did have insurance, so it wasn't great insurance. He had a huge out-of-pocket cost. And I have a business development manager, and he reached out to me and he was like, Crystal, there's this guy, he really wants treatment. He needs it. His out-of-pocket is ridiculous. This is what he can pay. This individual completed treatment and his payment plan is $20 a month. And let me tell you that I signed it because I'm not going to deny somebody treatment, right? Because our mission is to help everyone, right? Help everyone that I can. That is Synacor. Everyone receives treatment. However, let me tell you that every single month religiously, he pays his $20. He pays his $20. So there's always a means for some type of funding for someone to fall into that category to receive treatment. We figure it out.
All right, one last question. Go ahead. So how long are the individuals in treatment for?
So average stay for our short-term residential program is around 30 to 35 days. Our detox six, we also have a detox unit to where we can help the clients physically not be dependent on whatever their substance is, anywhere from 3 to 7 days, depending on if their protocol gets restarted from our medical director. Maybe their withdrawals are not going away, or they're need some extra time. So average about 10 days when that happens, but most of the time anywhere from 3 to 7 days for our detox unit, and about 30 to 35 days for our short-term residential program.
All right, well, thank you both so much. That's going to be it for our panel discussion. Of course, if y'all have any more questions, you can either let Ashley and myself know, and we can definitely reach out to Grace and Crystal for you guys. But yeah, thank you both so much. We're going to take a short little break before we begin our training. And of course, Grace and Crystal, if y'all would like to stay for the training, y'all are absolutely more than welcome. But if you choose to leave, again, thank you both so much. It was very, very helpful for sure.
Thank you guys for having us.
Yes, thank you.
Oh, we have something in the chat. Oh, Becca was just saying thank you.
You're very welcome.
All right, so y'all, we're gonna take, let's do like a 5-ish minute break and then we'll come back, okay? Yeah.
Got the graded, I got the eyes, laughing over there, and then.
I just wanted to. We're gonna make sure we're fixing our sound for a second. I think just volume. Okay, okay, much better. Alrighty, so we're gonna go ahead and we're gonna get started with our training. And so I want to thank Ashley Martinez for joining us. I'll let her, introduce herself, but we're gonna be going over the Seeking Safety curriculum, and we will be flipping back and forth between screens. So Ashley did prepare a PowerPoint that she'll use. Everybody who's here in person has the curriculums that they'll go over to follow along with Ashley. There is a worksheet that we uploaded in the chat so that everyone on Zoom can access that too. And then when we flip back and forth to show you the curriculum, we'll flip the screen and you'll see from whatever's on the screen, you'll be able to see when we flip to the dot cam. So like, for example, when we flip back to PC and we stop share, then you should just see. That's interesting.
Whoa.
Yeah. I don't know how that happened. I don't know what happened to Zoom. Oh. I guess I'm wondering if people on Zoom see the screen. I guess not.
I see the screen. I'm seeing the book right now.
Yeah, and I guess like when I flip back to PC.
Now I see the PowerPoint.
Now you all see the PowerPoint. Okay. And what if we I'm just making sure we have Zoom. This is what's really weird about it. I don't know why Zoom shows so many cameras.
Because you're showing at the screen. So it's like.
I guess so. Whoa, neat.
Taking a picture within a picture within a picture within a picture.
Wow. Okay. I think that might work out. So whenever we flip to dot cam, hopefully people can see it okay.
It's still a little blurry, but I mean it's.
Yeah.
We can sit there and like focus it for here because if we focus too much, it'll be blurry up there. So.
Right. We'll just try the best we can.
I'll turn on the lights over out there. That maybe what's doing is such a dark space over there. You get some faders on the right. Yeah. I mean,
Is there a light on like the dog cams, like the top of the black part?
But there's also.
Oh, maybe.
This might be on the arm itself. It's on the base.
Lamp. Yeah, got a little bit of a light. Alrighty, so if you want to start out with,
PowerPoint, I guess, at some point,
yeah,
whenever I need to go back. I really won't go back probably right away.
okay.
Probably towards the middle end.
And then I can put you in share mode
Mhm.
and then go back to Zoom. Share screen. Okay. Alrighty. So then I'll let you go ahead and introduce yourself. Can everybody hear us okay on Zoom? All right. Thank you all.
Good morning. So my name is Ashley Martinez. I am with MHID. I've been with the center or that facility for about 7 years. So that's the Oasis Center for Mental Health and Intellectual Disabilities. My purpose here today is to go over seeking safety with you all and really the importance of it and how you should use it. So my two main goals today is to make sure that you understand why to use it, how to use it, and make sure you follow the correct format. I've been teaching this curricula for about 6 years. I just did one training yesterday at my facility, so this will be my second one so far. If you have any questions, I recommend there'll be some times where we'll stop. I'll ask if you have questions. We'll do a little bit of some breakout rooms or practice for those online. They'll be in breakout rooms for those here. We'll have you guys in groups of 2 to 3 to actually make sure you're practicing it correctly. And I'll walk around and make sure that you're doing so as well. That's what we're going to be doing this today. Oops.
I'm going to show the PowerPoint.
This one.
There you go.
Okay. And so I'm just using this training that I got from the implementation guide. When I went to the training originally in Kerrville, right before COVID hit, I was able to meet with not Miss Lisa, but someone that worked on the curricula with her back in, I believe, the late 90s, early 2000s. So she was there to kind of teach the group at that point how to use it. And so I'm really basing my training off of learning it from her as well. So the title, Seeking Safety, and for those also in the chat as well, has anyone ever heard of the curricula before? Used it, seen somebody use it?
I kind of used it for my group counseling class for partner things that we did. So I've used a little bit of it. I haven't really done it.
Okay, all right. How did it go when you used it?
I really liked it. I liked how the format was. We did ours mainly not for the substance abuse part, though we used it for abuse.
Okay.
And so I really liked how the curriculum was laid out and how like there was different activities and stuff that you can go based off of.
Yeah. Yeah, it's helpful, right? It's pretty simple. It's straightforward. You'll realize, you know, at our center, there's a lot of curricula we use. This one's my favorite. It's simple. You really won't get confused. You can't get lost. You can't get it wrong if you follow the way it's laid out. If you don't, then you'll have some difficulty. But at this point, in the beginning, we'll go over how to do that. So the goal is the title, Seeking Safety. When you do this curricula, your point is not to provide counseling or therapy to delve into trauma. You are trying to establish safety as you help them process through that, right? So it's an evidence-based practice, working with people with comorbid issues with PTSD and substance use. When you do this curricula or training, be best to understand that it's not something that you'll master right away, because you also have to think about your comfort level when you do this curriculum, which we'll go to that in the next slide. So practitioners who can do it, anyone can do it. You don't have to have a special license. You don't have to have any special degree to do this training. It was made because of that. They started it off at, I believe, well, back in the 90s, early 2000s, in some impoverished areas in New York, the Bronx. And so they wanted to make sure that clinicians, individuals that could use it, could do so without having to go through the hurdles of college degrees and whatnot, because at that point, the need was dire. People needed to have this assistance as soon as possible. So when we have this program, you can do it without having any other special credentials. But with that being said, there is a personality that goes with it. And so with that, you have to be willing to do manual-based approaches. It's best to not try to take it on your own and kind of change things around. I know when I did present this a couple of weeks ago and yesterday, some people informed me that they really struggle with following manual-based criteria. They like to kind of go with the flow, see how it's all going in the session. But the problem with that is we are trying to create a safe environment. And to do that is to go with the manual. So that's the big thing with this. You can't just move around and kind of make it your own in that way. You also have to have positive interpersonal skills. So making sure you are aware of how you're communicating and knowing a lot about that power dynamic as well in these groups, because these individuals have lost power, not just to their trauma, but to their substances. And so your goal is really to establish or re-empower them. So more like empowerment theory, resiliency, you're going to be using a lot of those concepts in this model. Having that empathy is important, being respectful and genuine as well, because they know when you're not. Sometimes you'll get people, depending on if they're court ordered, they can tell if you're doing it just because, or if they're younger clients, they can tell if you're really being sincere, or if they're just victims, right? They can tell if you are there to help them or not. So making sure you're conveying that, because they're opening themselves to you at the most vulnerable part that they really don't want to talk about. They want to continue to do their substances because that's how they cope. And we're trying to establish safety. So when you're doing this as well, it's going to be present focused, empathetic, and person-centered. So going back a little bit to when you do this, making sure you're aware of your triggers, because you're going to be talking about the connection with substance abuse and trauma. You're not going to process trauma, you're not going to provide that therapy, but you're going to make sure you make that connection. So you need to be aware if this is going to trigger you. Because at that point, you really can't provide them adequate therapy if you have to work on yourself, which is okay. Just be mindful of that so that way you can attend to your needs. Because the last thing we want is for you to go into crisis or you needing extra help. Right? What you're going to be doing in this curricula too is providing some psychoeducation. You're going to educate them on terms and frame, making sure they understand these things, but also how they connect. You're going to go over some safe coping skills. So seeking safety is huge. In the book, at some point, I'll show you a chapter where there's about, I believe, 80 or so coping skills that if someone is struggling and they don't know how to cope, you have a whole list that you can process with them. You're going to help them manage their impulses. You're also going to help them manage their emotions. So it's integrated, like I mentioned. You're going to go and define the traumatic experience. You're not going to stay away from it, especially if you have someone that's not really comfortable talking about it. They need to kind of own what they've been through to process their substance use to also move towards safety. So you want to make sure you define that connection. The last thing, it's like I always mention, safety is the goal, not just of the person you're working with, the client, but of yourself. Because the last thing you want to do is as you're processing this with them, they go into more self-harming or destructive behaviors, and you haven't created the baseline of safety. So this helps you knowing that my goal is to create a foundation. My goal is to make sure that when they leave my office, whether it's group format or individual format, they understand ways to keep safe as they progress through their week and day. Some key points. It's early stage treatment. You can start this right at the beginning. You can use TF-CBT if you're trained in that. You do not have to use TF-CBT along with this curricula. However, where I work at my facility, I've done this with Jimmy and as well as some other counselors. When they did TF-CBT, I would, as the caseworker, do this as well, seeking safety, because it helped our youth, our clients, know as they're processing with the counselors their trauma, they're working with me on establishing a good foundation, which is really cool because I know I'm doing my part to make sure that when they go home and they go through their day, their school day, they know, okay, Miss Ashley went through this with me, Jimmy went through this with me, so I know how to make sure to keep myself safe as I process my trauma. So if you are, and if you do have groups or clients that are going to get specific therapy or certain type of therapy, and well, this is probably beneficial for them to know about seeking safety, that's something that you can help them with. And like I mentioned before, it's integrated treatment. So just making sure that we're aware of that. You're not going to do one or the other, you're going to do both. At any point in time, as you go through the topics, you are going to make sure that you redirect it back to both, because sometimes they're going to want to talk about other things because it's not comfortable. Nothing that's needs change is comfortable, right? But it's needed. So you always have to make sure that you're redirecting them back. So keep it present focused. So what they did in the past doesn't define them, but it does give us some knowledge and understanding of how they're coping now. So if they're talking to you about some things, whether it's in group or individual therapy, to where they're remorseful or shameful, we're not really focusing on that. We're like, okay, well, how can we keep you safe the next time something happens like that? Or the next time you're in a situation? We want them to feel empowered to be like, okay, we make mistakes, but let's just be more mindful of our safety. Idealistic, so we want to give them hope. They've lost hope. Or they might think they have hope, a false sense of hope, but then they might end up in dangerous situations. This practice is evidence-based. And the main thing is you're going to target 4 domains: cognitive, behavioral, interpersonal, and then there's going to be some case management. So you're targeting the whole person. Because at this point, when you're dealing with different systems and how they interact with different systems, you're going to need to know how they interact and make progress with their safety that you teach them. Right? It's not just how they're safe at home by themselves, it's how are they being safe in the community, at their job. They're having a hard day. How are they thinking? How are they processing? Are they damaging relationships? Are they trying, just because, they're processing so much that it's hard for them. So you are going to be doing a lot more than just CBT or therapy. You're doing a lot of case management as well, because in this curricula, you're going to have to know how to refer them to the resources in the community to make themselves safe, but also to find those resources for them. So making sure that when you do this curricula, you are aware that you're not just doing one, you're doing all. And it's your responsibility, if you know that they need some resources or referrals, that you follow up, right? There's 25 topics, and each topic has some guides and some handouts. So like I mentioned before, you will never be lost. It is there. I love this program for that reason. Because when I'm working with clients and I have to make sure that I'm managing their emotions, my emotions, making sure I know what I'm doing, it's helpful to know that I won't get lost, which is great, because then you don't know what's going to happen in that session. But you always have a path to redirect yourself to make sure that you're doing your goals as that clinician for them. It's engaging. There's going to be a lot of open discussion, making sure that you do that power dynamics when you have people in that group, they're not overtaking others. Making sure that you are also pointing out to make sure people want to participate. It's flexible in the sense of you don't have to go in order. Now there is a particular order with the first couple of sessions, but after that, you give them power to select which topic they want to go through. So you're going to hear me say that, safety and power, a lot, just because that is what we're doing. It's clinician sensitive. So it's really going to help you understand how to do this comfortably, how to not be intimidated by it. And it's going to be structured for their comfort. So we're using a lot of friendly terms, a lot of terms that aren't clinical jargon, to the point where you can explain it to them without even having to look it up and having to convert it into a simpler term for them. It's user-friendly. Like I said, I love that it's user-friendly, because I do not have time to stress out about how to make sure I do this right. And so I appreciate this curriculum for that reason. And that compassionate tone is important. So that's also going back to what I mentioned before, making sure you're prepared to do this curriculum. I would recommend, before you do this curriculum at any point in time in your career, make sure that you meet with someone, a supervisor or another LPC supervisor, to kind of process if you're ready for it. There is a point in time where you are, and it's expected that you practice it. So if you were to do this and you're not really sure, you always want to start off with topics 1 and 2. Read it yourself. See how comfortable you feel with explaining this. See how comfortable you will feel with teaching it. And then at that point, meet with your supervisor or your LPC supervisor, and then discuss that with them, your concerns. Because once you start it, you don't really want to cut it off and stop. You want to make sure that they get the full topic that you're going to be teaching them that day, and that you complete that topic because you want to establish safety. That's the biggest thing. It's also practical. So it's going to focus on rehearsal of new skills, psychoeducation, like I mentioned, and specific tools to help them move forward in recovery. So you're going to be an actor with them, which is great. If you ever wanted to be an actor and actress, this is your time. Because now when you meet with them, you will get to practice. They will not leave your office until they know how to do it. And that is how I am with my clients. And that's how you should be with yours, because you want to make sure they know what safety is before they leave. You're not responsible for their well-being once they leave, but you want to make sure you have provided them that tool. So you're just going to practice with them. Make sure they get it. Make sure they understand. It's relevant to different subgroups. So I work with youth ages 3 through 18. I'm in an intensive program. I'm with Yes Waiver, Win Wraparound, which is for families and youth who are at risk of leaving their home. And so when I work with my kiddos, we have a lot of youth that go into residential treatment facilities. We have a lot of youth that some parents give up their rights for, and a lot of youth and families that are having a hard time because of substance use. And some parents, you know, they really don't understand that connection between trauma and substance use. So knowing that if you do prefer to work with adolescents or you do prefer to work with adults, it can be used in either or, male or female. Different demographics from military veterans to criminal justice. The age to start this though is 13. So 13 and up. It can be combined with other treatment, like I mentioned. It's not a requirement, but it can be combined. It's encouraged too, if you know your client is receiving some other therapy elsewhere, it's best to incorporate it. And like I mentioned before, there's simple, engaging language. It's easy for them to understand. Okay, so I gave you guys a handout. And for those on the chat, it's going to be on page. For those on chat in your book. Page 179 in the book, but in your handout, it's the last page.
Laptop in case anyone has a question. Sorry. Okay.
You have your packet and it's going to be on that last page. And for those in the book, it's going to be on 179.
If you want anyone on Zoom to see it, you could just stop the share and I think they'll be able to see it.
Oh, they'll be able to see this.
Yeah. So that's probably going to be what they'll see. You can kind of see from that screen. That's probably the best. Let me see if I can adjust it. Yeah, I mean, that's going to be the best that they can see.
Okay.
But yeah, everybody here sees that.
Okay. So with the self-care questionnaire, I ask you guys to go through it and complete it. Mark yes or no for self-care. What are the things that you do and what are the things that you don't? It's pretty straightforward. There's no maybe. So sorry about that. It's yes or no. There's no in between. I'm sorry. And then I'll give you guys about 10 minutes to complete that.
What page was it again in the book?
179. No, sorry.
Hi there.
Yes.
I'm having a hard time. I'm having a hard time downloading the safety document. seeking safety.
The one that was in the chat box?
Yes.
So we can see if we can email it out, but we won't get to that till a little bit later.
Oh, okay. So then what am I supposed to be?
You'll go to
Access-
page 179. Oh, she doesn't have the book. Oh, I
Right.
see.
All the
Okay.
books are there, right?
Yeah, Narina, it's okay though. We have a PDF file that we'll email you directly.
Okay, sounds great. Sorry.
No problem. If anyone's having trouble downloading it, you can put your email in the chat and Melanie can email it to you all.
Depends on how you view it. So I'd let you decide.
If I personally don't like using contraceptives, can I just put yes?
So it's the eye of the beholder, right? So it's the self-care questionnaire, because it's different for each person. It is interesting as you go through it, right? You realize self-care can be as simple as brushing your teeth or having insurance or making sure that you have the common necessities that we sometimes don't think about. And for those in the chat, if you could put done in it in chat, so that way I know you guys are done with the questionnaire. And then just make sure you total up your score of no's. How many no's did you mark? So I don't know if anyone on the Zoom call is complete. But if you are, please mark done in the chat, so that way we can kind of move forward.
Did they see the back?
And there's 2 pages, so it's page 179 and 180.
So I'm sorry, actually, the only one that was in the chat was the 25 topics.
Yes,
So you don't have a PDF of this?
no, that's in, well, if they don't have the book, then
Gotcha.
they won't have it. But if they
Okay.
do have the book at home, then they should see it.
Okay.
Mhm. Okay. So for those who had the book at home or also here and you completed it, I like to go around and ask, I'm not gonna ask you what you put, right? Not that nosy, but I am going to ask how many no's you had, right? So how many no's?
12,
12,
So
7?
11, 14, 8, 12,
and
Okay. And anyone in the chat that's on 12? Honesty is key, right? It's good to be honest. So and April said she has 12. And so the point of that, if you look on page 180 of your book, or if anything, on the worksheet ahead of you, you're gonna see notes on self-care. The reason why I bring this up is because what your goal is also is to start new behaviors, not stop old ones. And so here we have self-care and PTSD, talks a little bit about it. So people with PTSD often need to learn to take good care of themselves. So for example, if you think about suicide a lot, you may not feel that it's worthwhile to take good care of yourself and may need to make special efforts to do so. If you were abused as a child, you got the message that your needs are not important. You may think, if no one else cares about me, why should I? Now is the time to start treating yourself with respect and dignity. Right, so we do see that a lot with trauma and substance use. They stop caring. And we want to make sure that they do care about themselves through the empowerment, instilling that power once again. And that could be just as simple as starting some basic self-care goals. And so self-care and substance abuse, excessive substance use is one of the most extreme forms of self-neglect because it directly harms your body. And the more you use substances or abuse substances, the more you are likely to neglect yourself in other ways too. So as you've seen, it could be poor diet or lack of sleep. It all starts to fall off at that point. But what we want them to do is not to make these huge changes, right? It's kind of like when New Year, New Year, new me, you're trying to do all these cool things about yourself. But what's more important is to start off slow. So try to do a little more self-care each day. So as it states here, no one is perfect in doing everything on the questionnaire at all, or really at all times. However, the goal is to take care of the most urgent priorities first and to work on improving your self-care through daily efforts. So progress, not perfection. And that's something too in this curricula you're going to see is progress, not perfection. Because nothing is perfect and no one can claim to be perfect, but they can claim really good progress. So, like I mentioned, part of this, we're trying to develop behaviors, we're not trying to stop them. So of course we want them to stop using substances. Of course we want them to stop self-harming, self-mutilation, or doing other behaviors that are dangerous to themselves or others. But telling someone to stop is trying to have power over them. Like, I need you to stop doing that, right? It's not helpful for you. You're hurting yourself. Can't you see that, right? That's not empowering. If anything, it's debilitating. They've already lost their power. So your goal and the point of this activity, one is to see for yourself, what are some behaviors that you need to improve on? That you're just like, I thought about it, never really maybe put action into it. But if you're asking somebody, especially who has substance abuse and trauma, to change and improve behaviors, well, try it for yourself and see how easy that is. I can guarantee it's not, it's hard, but it's something that you can express and explain to them that you've tried also how to do certain things about improving behaviors and you know how difficult it can be. So knowing that the point too is we're trying to develop new behaviors, reinstill them that they might have lost. So which behaviors will assist them in recovering a critical life function? So the activity that you did is in your books, it's part of one of the topics. But it is helpful to even have them start that in the beginning because you get an idea for yourself of what they've lost. And maybe at that point too, what you really need to focus on when it comes to that case management component. So like I said, you are looking at all these different levels, the person as a whole. And so with this worksheet activity, through a case management perspective, or how am I going to help them find some resources in the community? Maybe they need insurance. Maybe they need to find some other necessary needs, food stamps, or maybe they need housing, or maybe they just need some regular daily care items. Because to be honest, and I think we all can agree, if you are struggling with food or you don't have insurance, the last thing you care about is sitting in front of someone talking about safety, right? Because I need somewhere to sleep, I need insurance, I'm having this pain. So that is why this curricula is based on the whole person. Because we realize we want them to improve in this area, but how can we say that if they're lacking in all these other necessary things? But you target it all at once. Right? Because unless they have some, psychotic features or they need medication stabilization, They don't have to be in any type of recovery to start this curricula. You can start with them. Because if you start, then you're going to get all these components to further help them along the way. Okay. So you want to also look at behaviors that improve their barriers to recovery. So let's say they do this questionnaire and they're putting some things on there like, okay, this is pretty important. I want to work on this with them, but there's others that take some precedence. So you kind of want to focus on that with them, give them the choice, right? But also kind of encourage them to, I know you want to work on this, but also wouldn't this be helpful? Let's kind of talk about this a little bit more. And we know recovery progress is a direct result of usefulness.
For those of you online, it kind of, we're having some issues. We're trying to get it back online so that y'all can hear things. Just hang tight, okay?
Okay, I think we're back on. Can everybody hear us okay again? All right, awesome. Sorry about
okay.
that. Let me just minimize this.
So once again, we're trying to improve some behaviors. We want to make sure that there's no barriers to that recovery, but then also too, your relationship with them is just as important. So making sure you're understanding of all their needs, not just the ones that they should work on, but also giving them power to be like, I want to work on this too. So if you're not used to person-centered treatment, you are not the professional in their life. They are, just like you're the professional in your life. Right? You know all about you and they know all about them. So your goal is to make sure that you are supporting that, you're collaborating with them, because you're really you're a guide, right? You're not an expert, you're a guide with them to make that improvement. So some common elements for person-centered, some advanced skills for understanding and following the client, making sure that you are at their pace. You're working with someone who's been using substances for a long time, who's repressed their trauma, so be patient with them. But with that patience, make sure you're encouraging them to practice what you're teaching them. I already mentioned that interpersonal context, which is very important. So working on your people skills if you need to. Making that constancy is important with the personalities that you're meeting with. So if you know your personalities might clash, if you know your group that you're having has got some strong personalities, be mindful of that. And then making sure you're building skills for individualized issues around recovery. So a lot of these exercises and activities are chosen by them, like I mentioned, but you can help them apart from the first two. You're going to match the interpersonal activities, exercise, and discussion with the person and on that level of readiness and motivation. So it goes back to instilling power with them. They need to work on this one topic, but you can't force them to do one topic if they don't want to do it right then and there. And you want to increase motivation by tying activities to a lot of their concerns. So at some point in this curricula, there's a commitment, which is kind of like a homework at the end, which we'll go into when we go into our practice. And that's the time where you can really tie their concerns to how you can meet those needs by assigning them that homework or that commitment for them to follow up before your next session. And it could also be likewise, what am I going to do to help you before your next session? So the PDF file that's in the chat, but then the one you guys have in front of you, which is, it's on a separate page. This one. 25 topics. This one, I find it helpful because the book is, I don't like carrying around books. It's too much for me sometimes. So I was able to find this worksheet or this handout that briefly goes over what each topic is about. And it also tells you what it's targeting for domains. So I find that very helpful. So when we're looking at it, the first one is Introduction to Treatment and Case Management. This one doesn't have a domain it targets because one, it's the basic one. It's the first one you should read regardless. So like I mentioned, you can jump around in the topics, but you have to do the first two. There's no ifs, ands, and buts about that. You gotta do the first two, and after that, they can move around. But what topic one's gonna cover, it's gonna cover the intro to treatment, getting to know them, and assessment of case management needs. So if you're not familiar with case management, or really it's general social work. So if you're not familiar with that concept, that's what this is going to talk about. Though I say it's for you, there's also a participation with them. So as you, the clinician, goes and you review it by yourself for that first hour or two or day before, when you meet with them, you already know what that topic's going to be about, and you're going to educate them on what we're talking about. So when we create and we talk about a safe space, it's safe because they know what we're talking about. They know what to expect. Nothing is a surprise. And that's why we go back to saying they get to pick, right? Because it's not a surprise. So this whole process is empowerment. Now, safety is combination. So at this point, we're looking at the first stages of healing, PTSD and substance abuse, the key focus of the treatment. And at that point, you're going to get a list of 80 coping skills, and they can explore what safety means to them. Topic 3, PTSD, taking back your power. This one's going to have 4 handouts. The handouts are going to be what is PTSD, the link between PTSD and substance abuse, using compassion to take back your power, and long-term PTSD problems. So this topic, the goal is to provide information as well as compassionate understanding of the disorder. Because you're going to get a lot of people that say, my doctor diagnosed me with PTSD, like the military, right? I'm like, okay, well, that's one way to explain it, right? So you might have to make sure they understand what it means, and explain why we're talking about it. Detaching from emotional pain is behavioral. So you're working on this behavioral skill at this point. It's a powerful strategy, grounding, right? I'm sure you guys are familiar with that. It's offered to help patients detach from their emotional pain. 3 types of grounding are presented in this topic. So you're going to have mental, physical, and soothing with an experiential exercise to demonstrate the techniques. The goal is to shift attention toward the external world away from negative feelings. So that's going to be your topic there for detaching from emotional pain. So what I'm going to ask you to do now is to go through this handout and just circle which ones stand out to you. If you were a client receiving this treatment, which ones would you like to do? What would be interesting?
What page is this in the book, actually?
So this one isn't in the book. This is that PDF file that was attached earlier on.
Oh, okay. You have an extra handout up there. Anywhere else?
Would anyone be willing to talk about which one you selected and what was interesting about it?
I selected taking good care of yourself,
Why'd that stand out to you?
because I feel
Yeah, taking good care of yourself, a behavioral skill. So at that point, we're going to really guide them to explore how they take care of themselves. So that goes back to that handout, that self-care one, right? So that's where that handout, that questionnaire came from. So we're going to ask them to take immediate action to improve at least one self-care problem. Remember, that goes back to starting new behaviors, stop old ones. Right? Anyone else?
I picked compassion. I thought this one was a good one because it's really common to blame yourself for what happened, and beating yourself up about, having these lasting effects. So I thought that would be good to kind of help provide that help to see like you can love yourself.
Yeah. Right. The saying, love yourself before you can love anyone else. And that kind of proves true when you have compassion. They don't have compassion when, well, they might think they do, right? And they're trying to cope, like I'm caring, I'm coping, but they're being more destructive. Right? So really that compassion of how we can teach them to love themselves while setting boundaries. Anyone else?
So two I thought were linked together,
Mhm.
was red and green flags and getting others to support your recovery. Because you could argue that some people that are, whether they're suffering from PTSD or substance use disorder, have a red-green deficiency when it comes to interpersonal relationships. And being able to help them work through healthy identifying the differences between them and how they may relate to their social environment, interpersonal relationships with their significant others or others in general, their family, their work, all that would be interesting to go over from a cognitive perspective.
Yeah, definitely. You get to see how cognitive and interpersonal, how these things all work. Anyone else want to share?
I chose meetings, and I personally, not even in this system, but in just any system in life, I find meeting is probably one of the most important things, because you can go through every, point on this, but if you don't have a meaningful relationship with yourself, and with the outside world, it kind of falls by the wayside. I think meaning, living from meaning and purpose is kind of a driving force for that, like person-centered motivation and sure you live a beneficial and healthy life. So that one stuck out to me the most.
Yeah. Really making sure they understand, like I said, what is meaning? What is meaningful to them? How do they perceive it? And how can we make them show that more? Then they can relate that too to getting others to support your recovery, right? So when we think about meaning, who's meaningful to me? Right? So they all connect in this weird, intricate way, but it's helpful to understand when you go through these, and when someone is sitting in front of you and they're selecting and they say, I want to work on this, you are able to briefly explain what it is. So that way they're just not, one, surprised when you start, but two, you know that they're leaving with some better understanding of what's going to happen. And Narina said honesty. So for her, she said that she would like to work on that one. It stood out for her. Could you type in the chat why that one stood out for you? Honesty. Now she types this, so we know that. And if she does, so honesty, patients are encouraged to explore the role of honesty in recovery and to role play specific situations. So related issues include, what is the cost of dishonesty? When is it safe to be honest? What if the other person doesn't accept honesty? And I think that's something too, when you think about interpersonal relationships and you're saying, well, people should be honest, but what if someone doesn't accept that? Then they have to deal with it. They might feel rejected. Then they might go and self-harm through substances, right? Because then they might come to your session and say, well, I was honest. I tried and they didn't accept it. And then I left and I used and I'm here again. Just being mindful too that that might happen. So when you're going through this list, being prepared to for those tough cases, which we're going to get into in a little bit. And so this is some other just slides about which ones are different. So I found this online. Like I mentioned, I think it's helpful to have it with you, especially, you know, when I'm at my office, I like to laminate it. When I have the youth in our office, I'm able to sit there, they get one, I get one, and then we talk about it. So they can select from there. So that way they once again, they're not surprised. So if you are going to do this even in groups, you can pass this around in a group if it's laminated, and you can give them like a dry erase marker, or even if you just have extra copies and they can select ones that they want to work on. So that way, you know, okay, as a group, we've decided this and you're aware of what you're going to work on and nothing is going to be a surprise or forgotten. The last one is termination. And it's just like the beginning one, where the beginning one is case management skills and those basic social work skills. Termination is number 25. So they're going to express their feelings about the endings of treatment. They're going to discuss what they liked and disliked about it. And they're going to finalize aftercare plans. So there's an optional termination letter. It can be read aloud to them to validate the work they've done. Something you'll note too in this curricula is at every point in time and at every session, at the end, they're able to give you some feedback. So making sure you're comfortable with constructive criticism and feedback. It's not to say you're doing incorrectly, but maybe they just need to tell you, you know, maybe your approach was wrong this way. Because you're giving them, once again, power, right? It keeps coming back. It's this constant discussion of giving them power. So back to the chat when we were talking about the list. Narina said honesty. She talked about that her son and daughter is gender fluid. They're addicted to meth. They struggled with how they cannot be honest because they don't want to disappoint them. And so they are dishonest with themselves and with others in their lives because of their shame. So we even have our own personal reasons as to why some of these stand out to us. So when we think of that too, taking on that personal context, no, I'm not saying to use this in your personal life. As a mental health professional, I say I use this a lot with my family. My husband, I'll just kind of go into case management therapy mode, which probably isn't helpful, but it is helpful to know I'm being aware of where they're at. And even then to what I learned from this curricula or others, how I can help them and being mindful of myself. Okay, so use of the topics is a facilitated, flexible, and dynamic activity. Like I mentioned, you don't got to use all 25. But if you do, the first thing is you got to do the first two at least so they can understand what it is. So topic number 1, intro to treatment and safety. So regardless if you have time or not, you got to do the first two. If you have the time, you can go through each one. They're independent of the others, but you can see how they blend into each other. And each topic has multiple handouts. So if you want to get your book, I'm just going to kind of give you guys an example. The shortest topic is asking for help. That's the shortest one. But all the other ones are just as important. They're just as beneficial. But if you are in a time constraint after you do the first two, it's recommended that you jump to asking for help because that is the shortest one. And that one begins on page, it's 159. I'm sorry. 164, it's asking for help. So each topic is laid out in a certain way, and we're going to talk about how each topic is laid out. Because it's important for you as a clinician to know in the event that you do use this. So you're going to start off with a summary. It's going to tell you about the topic. It's going to give you an orientation about it. And it's even going to go as far as giving you the format, which we're going to get into in a little bit. You're going to have some content, session content on the bottom. And these are your goals. Once again, I find this curriculum really helpful because you cannot get lost. It tells you what to do. And as a clinician, you need to know, what is my goal in this session with them? How do I know I'm actually doing what I'm supposed to do? Each and every topic has a goal section. So this is for you. This is what you should be doing. Your goal is to make sure that you discuss effective ways to ask for help. You need to research or rehearse with them how to ask for help and explore their experience in asking for help. So if in anything, by the end of the session, you're like, I don't know if I did what I had to do. If you go back to your goal checklist and you said, I did these things, then you did what you had to do for your goal. And then there's going to be another section as you flip the page, ways to relate the material to their life. Sometimes you're wondering, how can I relate this to their life? They might select it and they're like, yeah, this is what I want to work on. Well, how do I make this relevant? I don't know this person. I might not have any idea of how these substances affect them. I've never even been around a person who's used these type of substances. So how would I use it? You can do it through role play, and they'll give you some examples. And it's going to tell you to work on the approach handout sheet. And it's going to tell you how to do that sheet. If you're having problems in discussion, whether you're in group or one-on-one, lucky for you, gives you some questions to ask. Like I said, you can never be lost. It is right there. So if you are a person that gets tongue-tied or you get nervous or you're like, I don't really know how to go about the next step, revert back to your discussion questions. The book also talks about suggestions. It tells you at some point what you should be doing, be mindful of. It's on page 167. And then at some point, I know someone in the chat asked about how long each session is. I'm going to get to that in a little bit. But suggestions you might want to be mindful of. So for example, you may want to introduce the topic with a simple, forceful statement. So for this example, for asking for help, I'm going to tell you one of the greatest secrets of recovery you will ever hear. This is like a law of physics, and as solid as the ground we walk on, you need help from others to recover, right? So it gives you ideas on how to even start the conversation, how to present it to them, especially if they're coming in, this is their first stage of treatment, they have no other history before. How can I present this to them so they feel like, okay, I think I can do this, I have some understanding. You can do some out loud rehearsal. It's typically the most effective. It talks about that some patients have no one safe to ask for help. And so it's going to give you a lot of examples. So as you go through and you look, and each topic has a section, this is all set out the same. Each one is a little different, mind you, when you go through, but it's all there. This bottom part on page 168, you're going to see where it says tough cases. Now, it's not telling you how to navigate a tough case. It is telling you to prepare for these responses during this topic. So each topic has a different tough case section. And these tough cases are what the client can say to you as you're presenting it or as you're going through. So the point of it is to just prepare, be mindful of how am I going to respond? How am I going to make sure that I'm not ignoring what they're saying, but I'm also there to kind of guide them back to what we're talking about. So for example, if I were to say, I'm going to ask someone to respond to me. If I say I'm always helping others, but no one helps me, what would you say to me is if you were trying to encourage me to do this?
I would say, what things are you doing for others?
And then I might say, well, nothing. Kidding.
Can you think of something that you can do for yourself?
I don't know. Sometimes I have a hard time doing that. I like to just go use when I don't want to ask for help. Okay. So another thing is I love role play. I thrive on it. It's so much fun because you get to enhance your skill with others. But when you get stuck, right? That's kind of why you want to be prepared, because they'll say things that you're not trying to solve their problem, but you are trying to get them back to the topic. So if they say, well, sometimes I just want to go back and use, well, I understand that. And I know that's difficult for you. And so that's why I want to work on asking for help, because I know it's difficult for you. And I know that you have some trouble and no one's there to listen to you. So when we work on this curricula together, we're going to learn how to do that. So then if someone gives you a negative response or you don't know how to refer them back to a positive topic, then relate them back to the topic that you're supposed to talk about that day. So that's one technique you could do, especially if they're going to present you with some negative kind of final discussion, right?
Or for that first one, turning it back to the client and maybe exploring like what their expectations are. Like what are some things that they would like help with that they feel or are believing that no one is there to help?
Yeah, so having them start to cognitively think, right? So it's not just, well, one, they're just sitting there, someone give me the help, I need help, right? But then they're forced to think about it too. And really give you some help to know, okay, well, whatever they give me, can I use some case management skills to maybe find some resources or maybe pull someone in or help them identify other people that can be there for them? But if not, what can we use also in that session? So yeah. So before we move on, you're going to see that every topic has these couple of pages. So when you do this curricula, spend some time in those first couple of pages. That's for you. Now, sometimes they'll have a little story of a real patient. Of course, they pull out the names. Not every topic will have that, but it gives you an understanding of why it might be hard for them to ask for help. So once again, you can read that for yourself. But as you move along, you're going to see on page 170 a quote. And we'll get into how to use that in a minute, but each one has a different quote. On page 171, you're going to see at the top left, it says handout 1. That's the ones you make copies of and you give to them. So that's the first thing to know about this book. You're going to have the first few pages are for you. And right when you see handout, that's when you need to start making sure they have copies of those documents. Okay. So with this being the shortest topic, it might not have a lot of handouts. I can tell you this, the first one has a lot of handouts. First topic's got a lot. So there's that. But you're always going to see at the top, it's going to say handout. Ideas for commitment we'll get into in a little bit, but that is also something, it doesn't say handout here, but it is a good tool to have them print or you print and give to them, they can have an idea. So going back to each topic has multiple handouts is kind of why I wanted to show you guys that real quick. I know they have CDs, and I think the CDs have maybe the PDF versions of it. I'm not sure. Normally I just fold my book, put it on the scanner and print. That's how I do it. But if you do have a CD or if the university does, then at that point you could get those saved. Okay, so sessions are structured for effective use of time, and it's based on the client-centered considerations. So the structure of the topics is very important. This is what we're going to role play and practice for most of the end of today, because this is the most important part. Because as you've seen before, the topics are laid out in a way that you just follow that narrative. It will tell you what to do, when to bring something up. But the layout of the session is where people mess up and then it kind of goes off skew. So when you do seeking safety, it's on that packet I gave you. It's a session format. It's always going to start off with a check-in. And then in that packet I gave you, the next page shows those check-in questions. I was able to find this one for some reason online. I didn't have to use my book, but the other ones weren't. But I also gave it to you in person in the event that, because I was hard finding it, you can just make copies of it right then and there. So you always start off with a check-in. So the check-in, you're going to find out how they're doing. You're going to ask them to report on 5 questions. So since the last session, the first question you'd ask is, how are you feeling? That's it. Don't add anything else to it. The next thing you would do is, what good coping have you done? Then you'd ask them any substance use or other unsafe behavior. Number 4, did you complete your commitment? And number 5, a community resource update. So like I mentioned before, commitment is like the homework you give them at the end of the session. Community resource update, typically, if they have a community with a lot of substance abuse treatments, facilities or centers, or even then just if they're utilizing their community to make progress, you want to see, did you reach out to this facility? Did you reach out to this? How did it go? Was it difficult? That type of thing. So you're always going to start off with a check-in. Something with the check-in is you do not want to use that as a time to explore more. You keep it at that. The next thing you would do after your check-in is you go to the quote. So if you go back to your book on page 170, every topic has a quote, like I mentioned. And what you need to do is you have to emotionally engage them in the session. So you ask them to read it out loud. And then you would ask, what's the main point of the quote? Because you've already read those pages about what that topic's going to be about, you're familiar with it because you spent time before meeting them to go over it. Whatever answer they give you, that is your chance to link that answer back to the topic. Right, so if I'm sitting here and one of you were to ask me to read the quote and I say, and the trouble is, if you don't risk anything, you risk even more. And you ask me, okay, what does that mean to you? And I say, well, it means to me that you have to do some risk to make progress. And there's no right or wrong answer. It's just their interpretation of it. And if you're in a group setting, you would go around the group and you get everybody's feedback. But then at that point, it's your job as the clinician to tie it back into the topic. So validate, okay, that's a great interpretation that you have one-on-one or go through each person in the group. So that's why I mentioned it's good to go back and make sure that you are prepared to talk about it. Because I've seen people, like I said, I work at a youth facility and they tell me I tried it and the kid called me out because I didn't know what I was talking about. Well, yeah, because you're trying to relate the topic and the quote and they found out you didn't know what you're talking about because you didn't spend time reading the before text. And then you're starting to struggle. So making sure that you are being mindful of that. Now, after you do the quote, you get into the meat of everything, right? So that's when you go back to your little session format. In this part, you're going to relate the topic to their life. So you're going to connect the topic meaningfully to the patient's experience. This is the heart of the session, using specific and current examples from their life, and you're going to offer intensive rehearsal of the material. So you'll even see too, it gives you some time frames. It's about 30 to 40 minutes of that session, right? So you have the check-in might be 5 minutes. If you have a group, it might be 5 minutes, right? The quote might be 2 minutes, but the main part, the meat of the session is going to be 30 to 40 minutes. And that's when you would have, at that point, start going through the handout with them. They talk about it, they complete it with you, so on and so forth. Now, if you're wondering, well, what's the protocol? Once again, this curricula tells you exactly what to do. You'll see A, you're going to ask them to look through the handouts. So you would have already made copies of those handouts, right? So the handouts that we talked about, let's say handout 1, you would have already made those copies. You pass them out to your group or the individual if it's one-on-one. You give them time to read it. If they have any questions, you can say, well, put your questions down, write it on the corner, and then we'll go through it. And that should take about 5 minutes. If you're working one-on-one, you can give it a little bit more time, right? And then at that point, once they go through it by themselves, then you start with the group or the individual. And after you do that, there's an optional, the safe coping sheet. There's those 80 copings that you could do. I recommend at every single session you bring that because you're always going to talk about trauma and substance use. So it's best to always end with your review of coping. Right? And that's in your book. I believe it's chapter 2, but that's optional, but I recommend to use it and have it available. But after you do the main topic, after the 30 to 40 minutes is passed, you're going to do your checkout. In your checkout, it's pretty simple. It's these questions. So your main thing is to reinforce their progress and give them feedback. You want to answer or have them answer these questions. So name one thing they got out of today's session and any problem with the session. So you're assessing if they were able to grasp what the main thing was today. Now, let's say at the end, you're like, they didn't get it. The next time you meet with them, do it again. You can do these over and over. There's no time strain, like that's it. You can go through all 25. And if you feel like they didn't make any progress, go through them all again. Maybe it was your approach. Maybe you probably didn't explain it well, right? But get their feedback. What is your new commitment? So their commitment to stay safe, which we'll go into next. And then you're going to ask them what community resource will they call? So if you're in a group, it says here about 5 minutes. You know, you can take about 5 minutes for that. If it's one-on-one, normally because I do it one-on-one, I give them about 10 minutes.
When you're doing the checkout, is it okay to just summarize what you talk about? And then you give them the option to ask them what they got out of it?
So yes and no.
Oh.
So you would want to summarize it, but you'd still have to go through and ask them.
Okay.
Yeah, that's just to make sure that everybody knows and aware of what did they get out of it. Even if they're like, I didn't get anything out of it. You sure? Are you positive? There was not one thing that stood out to you. And if not, I'm like, okay, well, thank you for letting me know. On the next one. So as long as you're presenting them the option to. And then it says there's an optional end of session questionnaire. So that one's optional. It's in your packet. And I believe it's also attached in the book. But it's not something that's required at each and every session. And in the packet, it's going to be in the book on page 60. So typically, I would like to do the end of session questionnaire every other session, kind of space it out, see how we're doing, what progress we're making. You can do it at every session, it's okay. So at the end, the biggest thing, and it even has it at the bottom of page 54 in your book or the session format handout, the main picture is to eliminate substance use, reduce PTSD symptoms, and increase safety, not just from our basic means of, self-mutilation or things like that, but also from HIV risk, domestic violence, self-harm, etc. Because a lot of these things will bleed into the other areas of their life. So like I mentioned before, there's exercises, which are those handouts. Each topic is arranged in the manual to support both you and them. There's 2 sets of handouts. Like I mentioned, there's going to be some handouts for you, which you would have the book. And then there's going to be those for the participant. If you go to page 73 in your book, you're going to see on the top left hand on page 73 where it says therapist sheet A. So not every topic will have specific handouts for you, but some will. So like I mentioned before, the first topic is the longest because you're really going to do some more case management. And at that point, you want to make sure you understand what's going on. So real quick, just kind of want to give you an overview of what this looks like. You're going to have therapist sheet A, practical issues that we're going to talk about. What's the theme of introduction to treatment, case management? It's going to tell you what to prioritize and so on and so forth. Some issues and some therapist issues that you may have, emotional and therapist. You keep going, you're going to see therapist sheet B. So this one has the most handouts for you. So if you're not familiar with case management or social work foundation, social work, it's pretty much this: identifying their needs, coordinating services, making sure they have these needs met while they're in your treatment. So yours is filled out. It gives you some examples. But as you move along in this first section, you're going to go to therapist sheet C on page 82, and then that one's blank. So you have therapist sheet B as a guide. Therapist sheet C is for you to fill out when you're meeting with them for the first time. So like I mentioned, you got to do topics 1 and 2 first. This is topic 1, is intro to the case or treatment and case management. So getting familiar with creating treatment plans is helpful, because that's what you're going to be more so doing at this point. Really figuring out how you're going to help them, what's their goal, their current situation, starting off treatment that way. And then it gives you further examples as you go along in the book. So 84, 85 gives you some more examples, how to fill it out. And then page 86 is therapist sheet D. That one's going to be a checklist. So just by itself, that topic is a lot for you. It's not my favorite one because it is a lot. But these are all things to start and kick off. Typically, when I do this one, I do not finish this in one session. My sessions typically run about an hour because that's the amount of time I have with youth. If you do group, depending on how long that is, well, you would do intro to case management more one-on-one with them. But regardless, if you don't finish all this in one session, you can do it again in the next. But you really want to complete it because once again, you have to go through and read all this yourself. So those first couple of pages to understand. And then you're going to have your handouts for you. And then you'll have the quote. And then you'll see where it says handout 1, page 2 of 3, and that's where you give those handouts to them. So any questions on topic 1 so far?
The sort of like intake process. So a lot of our students at the sites that they're at, the sites that we have like an intake process. Would you do this like in addition to the intake, or would you kind of just take the information from the intake and put it into this?
I would take the information from the intake the site already has and put it in. Because at that point, you're doing double the work. So if it's relevant, you can just move it over. Right? and then review it with them.
To clarify that, would you still go over it though with them to reiterate what
Yeah.
you have the understanding?
Yes, so you want to go over it with them, saying, okay, this is the understanding what we're working on. This is your treatment plan. This is what I've identified as some needs. Right, so this is where I'm going to refer you. This is what I've got from this document. I moved it over to this one, and this is what we're looking at. So just being open with them and clear with them so they know. Handout 4 on page 93 is a seeking safety treatment agreement. It's not legally binding, but it is something to review with them. So it talks about the goal. The goal of this treatment is safety above all. I will try my very hardest to recover, including reading session materials, completing commitments between sessions, and reaching out for all help available to me. I am always welcome back, even if I relapse. The more I put into treatment, the more I'll get out of it. I understand that I may feel worse before I feel better, but that I should stick with treatment no matter what. Everything said in treatment will be kept strictly confidential. I am aware, however, that there are certain legal conditions where the therapist is obligated to release records. So if I'm in a serious danger or harming myself or others, if a child or elder abuse becomes known, or if a court subpoenas the therapist's records. I will strive to be totally honest with the therapist about my substance use. My safety, including self-harm, suicidal impulses, and danger to others, and any negative reactions I have to the treatment or the therapist. I will be on time for sessions and will leave a message if I need to cancel. If I arrive to a session intoxicated or high, the session will not be held. I will be escorted to a safe place, such as the emergency room, until I can return home or be sent home with a friend or in a taxi. Or today, Uber, Lyft, those type of things, right? Buying, selling, or using substances with another patient or alone anywhere in or near this treatment office is a serious danger and may lead to termination from this treatment. Urinary analysis and or breathalyzer testing, you could put will or will not, typically will not, depending on where you're at your site, will not be conducted as part of treatment. If conducted, it will be conducted as follows. So for example, I'm in a grad program and I did my internship at Dismiss Charities, which is a halfway house recreational facility or reentry facility. And so they always, for the inmates, when they come back and live on the site, they have to do breathalyzer and urinary analysis. So for me, I have to mark, that they will, because one, it's BOP, it's, government property, so they have to anyway. But if you're on a site that doesn't do it, you would just mark no. Now I mentioned it's not legally binding, but you're just being clear on some of the rules you're having for this group and one-on-one, right? Because you want to make sure that they're aware of things that aren't going to really fly, which is you can't come intoxicated. If you're in harm for yourself, I'm going to find a way to keep you safe by referring you out somewhere, making sure someone comes and gets you hospital. You can't force them to go, if they come like, I'm not leaving, that's why you follow up with necessary procedures, whether that's calling, anyone on their emergency contact list, or if, crisis services need to be started at that point to help them ensure safety. But in no way is this a legally binding thing. It's just more ground rules for your treatment that you're having for everyone. And on the bottom, you're going to see for group treatment. I will not discuss details of trauma or substance use to avoid upsetting other patients. I will strive to create an atmosphere of mutual respect. So no interrupting others, no physical contact between group members. Contact with group members outside of session is discouraged unless it is reviewed with therapists in advance to protect patient boundaries. To help everyone feel safe, it is essential that nothing a patient says in session is ever repeated to anyone outside of the group. The therapist, in return, agrees to conduct the highest quality treatment possible with respect and care to help promote your recovery. So once again, you're being clear. You're not hiding anything. Nothing is a surprise, because you're trying to make sure that you build that rapport with them. Now you can't control what they do, right? Outside of group, you would encourage them. These are the things. But the seeking safety treatment agreement is important because it just further sets that tone of what's going to happen and what they should expect, and how you're going to hold yourself responsible just as they should hold themselves responsible.
For the group, they have to sign.
Yeah, so they would sign for group and individual. So for group treatment only, it's going to be those ones below the bold.
Okay.
But if they're just like generally one-on-one, it'd just be the top part. But if it's group, it'd be the whole thing. But regardless, they're going to sign it. And this is going to be put in your own records that, okay, this is what you said. So if they come back and let's say they come to group intoxicated and like, no, I want to come to group. Well, after you maybe determine if they're coherent and they can speak with you, well, remember we talked about this, I'm going to have to send you home for the day or go, have someone call you. It's just another way to keep accountability. Mhm.
So I have a question on the first one for group treatment.
Mhm.
So for individuals who may be also going to like outside self-help groups,
Mhm.
like whether it be like AA or any other kind of individual-led trauma groups, where the discussion of those details may be a part of kind of how that group functions.
Mhm.
They come into this type of thing. Have you ever experienced that kind of clash of, well, we're not going to get into the gory details of the things here because that's where we're moving forward, not dwelling in the past.
Mhm.
Yet in those other ones, they're experiencing that. There's kind of a
Yeah.
dissonance they may experience. Have you ever experienced that? And how do you address it?
I haven't had it in my sessions, but if I did address it, I would set it off in the beginning. So just reminding them, kind of like how you did in other groups, you may do this, but in this group, we're present focused. So your skill too, when it comes to, people forget, they might just be so, emotionally charged and they start talking about it. Your skill would come in on respectfully redirecting them, right? So kind of jumping in, sorry, Joe, I know you're really passionate about this, but remember, we got to keep on present focused. We want to make sure we don't trigger other people. And we want to make sure we keep the environment safe.
Okay.
Right? So, but I would definitely use those examples in the beginning. So when you're having them sign this.
So we're kind of level setting the group from the beginning.
Yep, exactly. And then of course, on page 92, it shows how to get the most from treatment, which is pretty much everything we've talked about so far, but this is for them. So that's why it's important to do topics 1 first. And then topic 2 is safety. Starts on page 94. And with safety, you're talking about why it's important, how it's going to be used. It's the same layout as each and every topic. So as you go through, as you flip through, you'll see how it's the same, but each one's a little different. And on page 103, you're going to see the list of 80 safe coping skills. So that's the one that they say when you're doing your session topic at each one to have, just because you can say, we reviewed it. If you do your clinical notes at the end, I recommend to always review it. So when I'm doing my clinical documentation, I can note that it was reviewed, right? So I'm also protecting myself in that event because it's important because you're dealing with such a heavy topic. But it's not just reviewed, but you might identify some that they're going to try. And I'll let you know in bold, ask for help, reach out to someone safe. You might explore that more with them. So who? So you want to get to that point. Who are you going to reach out to? Susie. How are you going to reach out to her? Well, I guess by phone. Okay, but you said her phone is off sometimes. So how? You're gonna get to that point of you want to make sure they got a direct plan. It's step by step. So in the event that you follow up with them, you know exactly how they were to follow up with Susie to ask for help. Or inspire yourself. Carry something positive, a poem, or negative photo of a friend who overdosed. For them, it might be something that they remember that they love that person, that they do this for them. But it's to the point of where, okay, so is it a photo? Where is it at? Is it on your phone? Is it in your pocket? Is it in your wallet? It's behind your phone case. Where can you reach it when you feel you need to? Right? So you're getting to that point. And so those are all of the 80. So I recommend before you even give this to them, just like I said before, review them all and what your expectations are when you want to make sure that there's all these follow-up steps. Okay, so when you do this, you can do it single or co-lead. So you can have 2 people depending, or you could even do 3 people co-leading it, depending on how big your group is. You want to name the group. You know, you don't want to call it PTSD and substance use. That's not really trauma focused. It's kind of, you know, reminding them that I'm here for this, right? Keep it friendly, but keep it obvious to a positive, right? Supporting ourselves in recovery, something as you would typically create for a group. Make sure you have some rules. So ground rules. So you could use the sign sheet that they signed for the how they're going to act and participate. I also, the program that I'm in, I'm a supervisor of a wraparound program. And with that, we create ground rules for how our groups are supposed to go. And when we do that, we ask the people in the group, what are some rules that they want? So we give back the power. So that's another thing you could do. You could say, okay, we're going to create some rules. Does anyone want to make some rules that we make sure everyone in the group follows? Right, because you're always trying to do power and still their power. And then you're going to have different group sizes. So you can do this individually, but if you do it in a group, a small is considered 3 to 8, medium 9 to 15, and a large group is 16 plus. If you're going to have a co-lead, obviously make sure you guys are well aware of how you're going to split it up, where you're going to jump in, who's going to guide a section, things like that. If you have someone that, let's say your co-lead is really strong in redirecting aggressive behaviors, you know, make sure that you meet with them before and say, hey, so-and-so might be aggressive today. They told me they had a rough day. Can you make sure you're just aware of them, being there to help them and things like that. So just always communicate, always practice before. The length of time. So they can be held weekly, twice a week, or any other frequency. They can be an hour and a half, or any length. I'd recommend go shoot for an hour because you already saw topic 1 is a lot. And even though topic or asking for help is the shortest one, you still might want to have to, you know, delve into those steps of asking for help. So try to shoot for an hour. And like I mentioned, if time is limited, you're going to select some key topics. But if they're getting a topic somewhere else, if they're getting anger management somewhere else, or anything about stress, then you might want to not focus on that topic, but choose something else. So just being mindful, 1, because you've already done the intro to case management, you kind of know what other treatment they're getting out in the community. And 2, you can choose if you have a short time, especially if you're at a site that might not be long for your field internship. I only got this amount of time. Let me make sure I focus on all of these other ones after I do the first 2, because they're getting something else somewhere else. You want to make sure you're inclusive as possible. And you want to encourage them to apply these skills broadly, right? So they're there to talk about substance use and PTSD or their trauma, but they're also there to build those behaviors and positive coping skills. But when we talk about building new behaviors, start off small. So how can we use these coping in other ways? I've already mentioned using that case management strategy to support other services, guide them in the use of materials. And when I say that, you might have clients, depending on the age group you are going to work with. So like I said, I work with youth, teens. I had one teen that he just said, you know, Miss, I don't know how to read. I knew he knew how to read, but he was just being a little difficult, you know, but that's okay. I have patience. And so I would just sit there with him in quiet silence, be comfortable with silence until he was ready to begin. So if you're working one-on-one, you know your client well, you know the people in your group, being patient with them to encourage participation. Because at some point he realized that I was okay with silence and I was patient. And then he started to flip through and he started to read. He did have some difficulty with reading, so I was there to help guide him on the sections and what this was about, right? And that was when you give them the paper to review it before you start that type of section. But you want to make sure you guide them in the use of the materials. And then you can encourage them to sample it. So if you're doing group at a site and there's a lot of people that could benefit from this, someone is hesitant to join, you can say, okay, well, you can sit in and observe, just like you could in some other AA groups or whatnot, those, well, the open ones anyway. They can sit in and observe to see if they want to participate. So you're just allowing them that choice to see if they like it. So you want to adapt your approach to whatever symptoms, conditions, or circumstances are befalling them at that point. You also really want to teach them that coping is possible in any situation. Safe coping is possible. Even if the urge to use is there, it's possible to do some safe coping. It's not about the headlines, or it's encouraging headlines, not the details. So I don't need to know the details of your past trauma, your past substance use. But one, you want to make sure you connect the two. How are they connected? And how can we make progress moving forward? And I've already mentioned this before, but redirecting and containing the conversation. They might start off and talk about the trauma they went through, redirect them respectfully, acknowledge what they went through, but contain it back to the topic because you do have only a limited time, especially if you're in a group. I've already mentioned this before. Watch for power dynamics. Use methods to aid in full participation. So if you know any method that might encourage one client or participant to be more inclusive or participate, do so. Make sure you're giving honest, validating feedback. Like I mentioned, combining past focused and present focused techniques. And making sure you find out what good coping they've done, used, or tried, or were taught. Because then you can kind of help them modify which ones worked and which ones didn't. Because if you tell someone, try deep breathing, I've already tried that. I'm the type of person that will ask, well, show me how. And then I want to see them do it. Because, you can say it, but if you don't know what it looks like, or they said, well, I just do some deep breaths, well, I want to see, show me. I'll show you how I do deep breathing. You show me how you do deep breathing. And then we can see, maybe you just were doing it too fast. Maybe it really didn't work, or maybe you were doing something else while you were deep breathing. I don't know, but asking them, right? So what has they used, tried, or taught, and what's worked? Because a lot of the times you're going to get them saying it hasn't worked, right? Yeah, you guys can take a, 5-minute, 10-minute break? Mhm. Yes, we'll get like a 5-minute break and we'll come back. Mhm. Mhm. Okay. So Matt was able to find the PDF file of all of them, which is really cool. So I really, before we get into the role play and the practice, I kind of want to go over some of these extra sheets with you guys before we start. So there's going to be a list of topics handout 3, and this will be emailed to everyone. This helps you stay on track to see if you completed some, which ones you've not completed. And that way it also helps the client or the person know, okay, where am I at? Which ones worked for me? So that one's great. The safe coping sheet. So when we talk about, I think it's coming up soon. It might not be on here. Let's see this one.
I just emailed it to y'all, so y'all should have it.
So let's say we talked about commitments. Commitment is the homework that they do at the end. So when they have their commitment to recovery, you're going to see a page that in your handouts I gave you, and you're not going to have an email. There's going to be a top part and a bottom part. The top part is a commitment that they give to themselves for their recovery and to their therapist. They can't complete their commitment or they need to change it. They can, leave a message with you for their next session. But the point of a commitment is, what will they do to keep safe and by when? What community resource will they reach out to and by when? So that way they're always being mindful of safety. That could be, I'll call Sarah the next time I have her, wanting to self-harm through substances. When will I call her? I'll let her know today after the session. All right, so it could be simple like that. And then they can say, I'll set it up to where she's my favorites on my phone. Community resources, who are they going to call in the community and when? So they might want to call the council by when. I'll call on Saturday at 2 to get more information on the council. Then they will themselves put in their next scheduled session. Where are they going to keep this sheet to remember it? So it's kind of going back to what I said before. You want to get to the point where you know every little step that's going to happen. You want to make sure that they know. And they might not do it, but at least you talked about it. They can put it in their wallet, refrigerator door, a notebook, or they can put it in any other location that they know where to grab it from. And then you have your copy. What I like to do when I'm with the youth is I'll make sure that they write it down, and then I'll ask them to read it out loud to me. So I want to make sure they further remember what they're writing down. So I tell them to read it out loud, and then I write it down on mine. So in the event that they lose it, which most kids do, it's okay, I have my own. So they can't say they don't remember because I got mine, and we can review it before the next session. And then you'll have your end of session questionnaire, which we talked about a little bit before. They're being honest on how that session went for them. How helpful was it? In today's session, how helpful were these things, 0, 1, 2, or 3? You're asking them how much did today's session help them with PTSD and substance abuse? How much do they think they'll learn from the session in their life? So what will they use in the session in their life? Do they feel like they will? Do they feel like, I really won't use this in my life? Okay, I just want to know. I just want to have an understanding of where we're at. Because that sets your baseline. So though I say don't do it at every session, for sure do it at the first one. Right? So that way you have a baseline of progress as you move forward. And then do they have any other comments about the session? So they just, being honest, making sure that they can be both positive and negative. Kids will hurt your feelings. If you work with youth, it's okay. Have some tough skin. They might tell you that this is boring. This was stupid. I don't want to do it. That's okay. Put it down because it could change the next time. Right? But you're giving them the power to do that. So it's going back to that. And then you ask them, how could the treatment be more helpful for them? Now, because I don't see it on this one, let me check. I might have to change the screen. Here it is. Okay. So this is in your packet as well, ideas for commitment. It's on page 181 of the book. But an idea for commitment are one of these following. So they commit to one action that will move their life forward. It can be anything they feel will help them, and they can try some of the ideas below. Keeping your commitment is a way of respecting, honoring, and caring for yourself. So one idea of commitment, they can practice grounding for 10 minutes or more. Then they can rate their feelings before and after, just as we did in the session, right? Option 2, they can reread the handout, circling the methods that they want to try the most. Option 3, they can find something to carry with them that helps them feel grounded. It might be a beautiful rock, a picture of someone they love, an AA chip they earned. They're going to keep it in a safe place that they can access at any time, such as their wallet, their pocket, or a keychain. And then they fill out the safe coping sheet. So when they have the safe coping sheet, you're going to see an old way and a new way. This is to help them understand how their commitment operates, how it's supposed to carry out. So let's say they had a flashback, was their old situation. Having a flashback was something that they struggled with. They used to cope. I got stuck in it. It was awful. I tried to drown my feelings in 3 gin and tonics. And then they would put their consequence. I just feel like I have no control over my feelings. I can't stop myself from drinking when I get overwhelmed. So here you're making sure they understand their past. How did they cope previously? That past focus is where we're at right here. And then their new way. Having a flashback, same situation. A new way they can cope. I can try to cope with a flashback by doing some grounding. These are the ways that I think would work for me. Run my hands under cool water. Try to remember every major Red Sox player from the 1970s. Turn on some music loud to drown out the flashback. Right, so in this section in the present focus, we do see their coping, but we see it to a point to where it's steps. Because you want to make sure they put, I coped, I just deep breathed, it didn't work. Okay, what's something else we could do, right? So make sure they at least have 2 to 3 if they're going to do something with mindfulness for coping. Their consequence now is the intensity goes down, not completely away, but down enough so that I don't feel like I have to drink. Right? So like I said, we are not stopping behaviors, we are changing behaviors, adding new ones. So eventually the ones that are harmful stop eventually. And then they can rate how safe their old way of coping was and how safe their new way of coping. 0 is not safe, but 10 is safe. Right. So when you're trying to have them fill out their commitment for their next session, and they're like, I don't know how to, even though this worksheet is in, I think it's topic 3 or 4, detaching from emotional pain, you can use this as a tool to help them think of commitments, to help them think of, okay, I guess this can be my new commitment. Or even the worksheet that we did earlier where they did the self-care questionnaire, right? They can utilize one of those as a commitment and how they will follow up and by when. Okay, so now we're going to get into groups of 2 or 3. And I really want to make sure that we understand the session format. So it's not about the topic, because a topic you can read, you can get, and you'll be fine with that because it's going to guide you. The part I want to make sure you know is how the session is laid out. So that check-in, and then you're going to do the quote, introduce the topic, and then you're going to do the checkout, and you're going to review it a little bit. And then at that point, you're going to talk about commitment. Right. So we're going to get into groups of 2 or 3. If you want to stand up for this, so that way you're more in a better circle as opposed to rows. And what I'm going to do is I'm going to walk around and make sure that you guys are practicing it appropriately. For your topic, you can choose any topic because we're not going to go into the topic, but you're just going to use it as part of the conversation, right? So if you're going to use asking for help, you might say, okay, today we're talking about asking for help, but I want to do our check-in as we're normally supposed to do. And then you ask, one person will be the facilitator and they will ask the other those check-in questions and they'll go through the rest of that session format. Any questions? All right, cool beans. So if you guys want to get in groups of 2 or 3, and then we'll put the people in Zoom and breakout groups, I guess.
Lorena and Becca, I'm gonna put you two in a breakout room so that way y'all can work on it together.
Okay. So how did that feel?
It was hard.
Yeah, because you're counselors, you want to dig in, right? You want to solve some problems, but you can't, not in the beginning at least, right? You got to just stick with the questions. Don't go into it, but then as you get to your topic, you can bring stuff back. You guys did really well, especially when you did a lot of, or you note some concerning behaviors or something concerning that they said, mention to them that, okay, we're going to get back to that. So that way they know and you know that you're going to bring that back and it's not just going to quickly leave or escape the conversation. But the point of this was the format is hard to learn. Not to learn, but really to stick to. But the content is easy because it's all intuitive, it's there, you have those directions, you have those steps. So that's how we practice the format as opposed to going into the topics. When you do, and if you do use this curricula, just be mindful when you do terminate that there is a good follow through transition. That might be to another service provider, whether that's their doctor or a long-term counselor that they're going to be referred to, just in the event that they do or need a follow-up, right? And just know that you don't have to just do it all once and then it's done. You can go back and do more topics again if you feel like they didn't grasp it or maybe they missed something and they struggled. And so that is it. Is there any questions?
So do you typically do all like 20 sessions with a client?
Mhm.
So you'll see them once a week for however many weeks and go through every topic on this. It's 25, right? Yeah.
Mhm. Yes.
25.
Yes, if I know I'm going to be with them for that long. So I've been with my center for 6 years and I was a case manager for about 4.5 to 5 years. And I would keep my caseload for the same most of that time.
Mhm.
So I had the time to go through and I had the time to make sure that I could stick with it. Now, if I, of course, with youth, you know, they might not want to do it anymore. So you'd have to make sure that they understand why they want to stop. If there's really a benefit to them stopping, include the parent in that as well, right? Because you want to make sure the parent is aware of anything that's stopping with treatment, but typically, yes.
What impact, this is the last one. What impact did you see this having on your clients? Like what were some of the changes or I guess like the benefits that you saw?
Well, I used it with male clients. So that was interesting for me just because I saw that they were more open to change or just not really change, but to learning about it. So more teenage male clients ages 14 to 17, 16. So the change I saw in them where they were just more, one, willing to talk about it with me. One, because I didn't tell them to stop doing their substances, but more just, let's try to build other behaviors. So they were more wanting to speak with me because of that. I wasn't their parent that's saying, stop doing this. I wasn't saying it was good to do substances, but I would explain that I know it's something that you're having a hard time controlling and stopping. So let's build something else. So a lot of participation. My rapport with them was really good by that point. So they felt comfortable talking with me.
Mm-hmm.
There was a new client that I had. That was when it felt like pulling teeth to kind of get them to participate. But even then they could understand that I wasn't forcing them to change right away. So I got more participation and feedback.
Thank you.
Any other questions?
I don't know exactly what my question is, so I'm just gonna kind of talk out loud and just keep that somewhere.
Mhm.
So because the goal is not to get them to stop, but to get them to implement new behaviors that maybe will kind of replace over time. I can imagine that it might take a while, especially with you, because that's what you work with. Is it might take a while, a little bit longer to get them to stop. And so how do you get parent buy-in if they're not seeing the immediate result? Like when do you bring them into like, hey, this is what the treatment goal is, this is what treatment looks like. How do you kind of get parents on board?
So with our agency, when we do our treatment planning, it's that first meeting we have with them. So we explain to them what this curricula is. We explain to them the purpose is safety, to build new behaviors. The new behaviors will eventually replace these old behaviors. But at that same time, because as a case manager with the family, I would meet with the parent one-on-one to educate them, not through the curriculum, because the parent might not have any substance use or trauma, but the child does. But I will explain to them, this is what I'm working on with them. This is kind of where they're at. Mom, you might want to follow up with this, go into the community. There's some other groups out there that they might be helpful with. I'm seeing this as a barrier. They're making some progress here, but we are seeing them regress here. So that initial meeting I have with the youth and the parent, I talk about it. Sometimes I'll actually do one of the sessions with the parent in the room, like one of the first two. Typically, I'll do the safety one, topic 2, with the parent in the room. So that way the parent can see how the layout is and how the main thing is safety and how we're not trying to stop, but change and build upon new ones. Yeah, so it's a lot of in-between conversations and then sometimes pulling them into sessions. One, if the client is comfortable with the youth, like, I guess I'll have my mom in to see, but for sure that second topic would be the best time. Anything else?
My question was just about like, is there a structured order that you go into, or is it just really based off of the needs that you identify in some of those assessments?
After you do the first 2, it's whatever the client wants. So 1 and 2, and then they can choose.
So with that, like wanting to be prepared for the session, do you have them choose what they're wanting for the following week? So you have time to like brush up on that session?
Yeah, so like, let's say your first meeting with them, they of course start with 1 and 2. They do well. You've been on those 2 topics for about maybe 2.5, 3 weeks because they're pretty lengthy. But then by that fourth one, that fourth session, you would already know based off the last one. So now we're going to get into this one next week. So be prepared. We're going to talk about this. This is what this topic is. That's when you could use your 25 description list. So you can let them know this is what this one's going to be about. So we'll talk about that then. So, yeah. So there's no surprises. Anything else? No? Thank you for having me.
Wow.
It's just, yeah, it's kind of tricky. So whoops.
Yeah.
We're gonna give you all another break, and then after this, we'll have our virtual simulation activity and discussion. Thank you so much, Ashley.
I'll put this on mute.
Yeah. We're gonna have a short break and then we'll come back and we'll do our virtual simulation activity.
All right, so for my online people, we are going to be going over the case study again that the panelists had reviewed for us. So that way we can give y'all a chance to process. So I'm going to be sharing my screen again to pull it back up. Maybe. How do you zoom in? Oh wait, no. Is that better? Or do you want me to do more? Okay. That's fine. All right. So Kai is a 13-year-old third-generation Asian American who just completed his first year of high school. Kai's family originates from Thailand, and they often celebrate their heritage through holidays, family events, and food. But Kai and his parents are mostly acculturated to living in the United States. Kai's parents hold high expectations of him, and he often finds himself falling into the model minority myth. Kai shares with you that his parents expect him to make good choices, do well in school, have morally upstanding friends, and generally be a perfect child. He also shares that he feels like he can never measure up to the high standards of his parents, which makes him feel guilty and like he is failing them in some way. Kai jokes that his mom is the face of the Tiger Mom movement and states that she can sometimes be over-involved in his life because of her desire for him to do well. As you talk with Kai, you learn that he skipped 8th grade, which is why he just finished his freshman year. He mentions he didn't know he was going to finish and that it's been a big adjustment. Despite the age gap between Kai and his peers, Kai shares that he's beginning to make some friends and he feels like he's been accepted into a friend group that really accepts him for who he is. He shares that he doesn't feel pressured to fit in and he believes his new friends would be there for him through thick and thin. In a separate interview with Kai's parents, his mother shares that Kai has been acting a bit unusual for several months. She mentions that Kai is usually very energetic, talkative, friendly, and outgoing. Lately, she has noticed that Kai has been more reserved at home, a bit moody, and seems troubled in some way, but she can't quite put her finger on it. She also shares that Kai's grades have fallen since beginning 9th grade, and getting Kai a tutor did not seem to help. Kai's father confirms these observations and adds that Kai hasn't been as open with him as he usually is when talking about his friends and after-school activities. Kai's mother shares that at first she thought Kai's behavior might be a normal response to skipping a grade, going to a new school, and dealing with puberty, but now she is concerned that something else may be going on. When you ask Kai about his parents' concerns about his unusual behavior, he seems reluctant to answer your questions, but finally gives in. You learn that Kai's new friend group is actually a group of sophomores who have been known to have a bad reputation because of rumors that they are drug users. Kai admits he began huffing with his new group of friends because he wanted to fit in, but now he has started huffing even when he is not around his friends. You learn that Kai initially started huffing permanent markers with his friends and gradually experimented with paint from his father's garage. Kai states he got more experienced and began bagging so that he could bring substance with him to school. You ask Kai how often he used to huff with his friends when he first met them, to which he replies, only for a little while after school. I didn't want my parents to find out, so I didn't spend a lot of time with them. Initially, Kai would huff whenever his friends shared with him to socialize with them, but soon it began helping him to deal with the immense pressure of his parents and difficult coursework. Now Kai says he bags throughout the day at school by asking teachers to use the restroom and during passing periods. Kai shares that he feels like keeping up his behavior is a chore and he doesn't really want to be a bad kid in his parents' eyes, but if he goes for too long without huffing or bagging, he starts to feel the craving. You ask Kai if his substance use is part of the reason why his grades slip, and he shares it's hard to really care about anything except when I can escape again. I mean, I know that it's something that I've used, not a lot, but I have used it in the past. And I mean, I could see how it would be helpful. Because I think it was like what Grace had mentioned, right? That kind of getting to the root of the problem, right? So not only addressing the huffing and the bagging, but also figuring out, what's causing it. And so yeah, if you take into consideration the multicultural component of it, it could be that things from, within his the Asian American culture could be contributing to why he's coping the way that he's coping. And so I can see it being a useful thing for him. Right. Accurate. Yeah.
Like, we are not respecting their culture.
Right.
So that's why it's like an inventory. And using that as kind of what at home. Maybe we work collaboratively to help.
Sure. And like in the case study, it says that like, yes, they're third generation, Asian American, and, for the most part, they've acculturated to the United States. Yeah. And it giving like the professional values. Sorry, I have the chat up. We have a question. And yes, Narana, just give me a second. So where was I going with that? Yeah, so it could be that, you know, at 13, like he's going into a new school and so he's being exposed to, you know, new values and things like that. And so it could be that he's having these like contradicting feelings of like, oh, I like this resonates with me. And it goes against, you know, what I've been born and raised to believe. And so that could be cause for some of the stress, the anxiety, or whatever it is that's going on with him. Katie?
Like, so Tiger Mom doesn't care about any aspect except for high achieving. And yet, in this case, she is a little concerned about everything else. So it kind of clashes with his idea of being a Tiger Mom, because maybe all he's recognizing is, I've got to get good grades, I've got to do this. And she's over here like, what else is going on? Yeah. I think that can be what's going to be part of it. And when he was talking about the environment, like, Kai doesn't want to be his parents. That's his big thing. He wants to be successful, and you know, now he's found I can have friends and this, but at the same time, he's finding friends and hanging out with them. So there's just a lot of clashing.
Were you able to hear that? Can you just unmute yourself and tell me yes or no so I can hear the voice? I don't know either. Yeah, I don't know. Becca, were you able to hear what Katie was saying?
Your speaker up because,
I was gonna say I could kind of hear a little bit, but it's been hard to hear what everyone's saying. I'm kind of lost as to what exactly we're talking about or what the question was.
Yeah, so basically Matt had started us off by asking, you know, would some kind of assessment for Kai's like values, his personal values would be useful. And we talked about how, you know, he could be experiencing kind of like this internal struggle of wanting to be, you know, wanting to hold on to like his Asian American culture while still kind of adapting these new values and beliefs that maybe he's had since he's, you know, either started high school or whatever. And then Katie had brought up that, you know, the Tiger Mom movement is very much like, we're gonna focus on, you know, like the doing well academically. But then she pointed out that with Kai's mom being so like involved or caring about the other things that are going on with him, that kind of contradicts like his perception of his mom being a part of the Tiger Mom movement. Did I miss anything? Okay, so that's where we're at.
Okay, yeah, that helps. I was kind of lost.
Okay, cool. Mm-hmm. Mm-hmm. Yeah. Mm-hmm. So Matt was just talking about, you know, maybe like, he likes the idea of the family therapy because it'll give, you know, a chance to explore kind of what Kai is going through, you know, maybe that jumping into high school from, you know, going from 7th to 9th grade, maybe wasn't such a good idea, you know, developmentally, right? Because he was just getting adjusted to middle school. And then suddenly he's in an environment where, you know, there's older students and they're driving and, you know, just all these other things that kind of go along with high school. And so like, yeah, you know, he's smart, right? Because he jumped a grade. But maybe that wasn't the best approach to his situation. And kind of getting everyone just on the same page.
More about popularity than what's in your head.
Yeah.
Friends, maybe you just found a group that, you know, just automatically something. With my to find people with that I would be friends with. Probably, but you know, it's something easy out there. But I'll be, and then now you feel like that's all.
Yeah, so Katie was just saying that if you look at the social aspect of it, is that, you know, students who may be a little bit more academically inclined, they tend to not be a part of the popular groups. And so Kai just kind of attached himself to the first group of people that, you know, showed him any kind of like possibility of being a friend. And so now that he's a part of that group, he doesn't really want to or know how to make other friends, you know, because of that fear of just not being accepted by anybody else. Mm-hmm. Yeah. Yeah, and so Julie was mentioning, you know, just peer pressure, right? So he wants to be accepted by anyone, by someone, and so he started huffing, you know, to be accepted by the group of students he started hanging out with. Yeah, and so Matt was talking about, you know, how it was just, it's easier, right, to just, you know, huff this marker versus trying to put in any kind of emotional work to making friends elsewhere. Julie?
I was just gonna say that I think this is but I think a good method for like approaching this case might be choice therapy.
Okay.
Just because he's pursuing, like even reading this, I was thinking about the WTP. Like he's wanting to be accepted. He's doing that and then maybe walking through with them those things. And then the acceptance is one of those 7 things. That might be really helpful for him. And then I think also just but what you looking for? You looking?
Yeah.
Exploring like different expectations.
Yeah. So for my online people, we're just talking about, maybe choice therapy would be a good approach for him. Because, with the WDEP stuff, he's wanting to fit in, and then going over, acceptance is one of the 7 key core components of choice therapy. And then just exploring with him what his views on like what a good friendship and things like that would be. Do my online people have anything to add?
I like what everybody's saying.
Yeah.
And, so I think therapy would be great because like love and belonging is like one of those basic human needs that we're trying to meet, right? And so what's so important is the sense of belonging. And so kind of what Matt was saying, like should we assess values and should we also educate, our clients to help them be able to articulate what their values are? I think that's very helpful because then why do you want to know what someone's values are? I want to know that. So you can find out like what's important to them, right? Find out basically like what they prioritize and what is he prioritizing right now. What we're seeing is trying to really like fit in and relate to his peers, and then looking at like what he prioritizes and what they find important. Probably more like good choices, like being an achiever academically, right, morally, making good choices, and so they might have differences in what they value. So I think doing that would be very good for the client to kind of come to that understanding, like, okay, what is it? It's what I value and I find important, and maybe like a card sort, like a personal values card sort activity can be good to process that. But even like if you do family counseling, you can also like administer assessments to the whole family, see what they value, prioritize. But I do agree too that like him being younger, like how do you make sense of his values? And I think ultimately assessment is so important because that information is what will prepare you to know what direction to take from all of the information we've gathered. And I do think that the choices we make come from what we value, what we find important, what we prioritize for ourselves. School is probably not the high priority list. And also like with cultures, like understand too that like maybe he does have collective decisions, right? And what's known in a lot of like non-Western cultures is that they make collective decisions, right? Whereas like here in the United States and more westernized cultures, we make more individualistic decisions. And maybe for his family, maybe that's a concern that he's like kind of doing things without their consent or without like checking in on them. Like why is he like making choices on his own or finding more value like consulting with his peers about stuff? Or why does he want to have a sense of belonging with them? Maybe his family doesn't understand that because maybe he is like wanting to be independent and make his own choices and find out his own friend group that is different from what his family is finding important for him. So having those conversations.
Decided for you for your future, that's very long term and developmental. And so his parents are able to think long term, but developmental has not, his brain is still growing, his brain is still developing. And so he's still thinking the short term, what do I need to survive today? Absolutely with your friend group. And so here's part your parents something long term. Here's what short term. So how do we bridge that?
obviously, doing something about the sun, or even,
Mhm.
oh.
Mhm.
Are experiencing that model minority as well, and then it's being passed down.
Doesn't work. Right.
No, why not this really focus himself? He's younger than all, not for that friend. And maybe he feels that he's not being able to. He may not know much about the.
Mm. 8 minutes. Yes, we have time. We have some time. Are y'all ready for the virtual simulation? Okay. Anything else anyone wanted to add though, real quick from the case study? No problem. Yeah. Okay, so let me pull it up real quick. Okay, y'all ready? All right, so we're gonna do the same thing that we did last time. We're just gonna play it all the way through and then we will discuss it afterwards. So we encourage you all to kind of just jot down some notes or questions or comments, whatever you feel may be important for discussion. Yeah.
I'm Meredith. I'm your counselor assigned to Jane. If I can get this chair. Now, due to the nature of the circumstances surrounding your admittance, I do have some questions for you before we start. Do either of you, before I begin, have any questions for me?
Is it okay if I stay in here?
It's okay with me if it's okay with Jane. Jane?
Yes.
Okay. So it sounds like you took some Percocet after you and Michael were fighting. Is that correct?
Yes. She was.
Michael, I appreciate you being involved, but I do want to hear from Jane in this circumstance. So, Jane?
Yes, that's right. I was offered a teaching position at a prestigious riding school. And when I told Michael about it, he didn't want me to take the job. And he knows how much I want to be around horses again, so.
I see.
My bad, y'all. I totally forgot to give y'all some context to what they are talking about. Huh. Yeah, oops. Okay, so real quick, Michael, 32-year-old white male, brought his girlfriend Jane, 30, Hispanic female, to a local ER due to an accidental overdose on pain medication. Jane has been struggling with her addiction to pain medications for 5 years now. She used to be a professional equestrian and was practicing jumping one afternoon when she and her horse took a bad fall. Jane ended up breaking her leg in 2 places, fractured her collarbone, and had a serious head injury that resulted in her having surgery. Jane was in the hospital recovering for 6 months. Upon her release, she was prescribed Percocet to help manage her pain. When Jane was told she would no longer be able to compete professionally, she took it pretty hard. She turned towards her Percocet to help cope with the emotional pain as well as the physical. A year after her accident, Michael noticed Jane was still taking her prescription and was having them refilled quicker than what she should have. Michael confronted Jane about it, and they got into an argument. Jane left Michael and moved in with her mother. She continued to abuse her prescriptions until her mom kicked her out for it. Jane then returned to Michael and said she would be willing to work on her addiction but needed his help. Michael agreed, and Jane attended an intensive 30-day inpatient program. Jane has a history of negative coping skills. When her parents divorced when she was 6, she ran away from home. When she failed to make her junior Olympic equestrian team at 16, she coped with alcohol. When she and Michael have had arguments, she either turns to her prescription or threatens to kill herself. Jane does not have a history of previous suicide attempts, but rather admitted to using it as a means to make the arguing stop. Jane had been doing well with her recovery until about 3 months ago. She and Michael had been fighting more frequently, and their arguments have gotten progressively worse. Tonight, Jane and Michael were arguing about a job Jane got offered teaching jumping. Michael was not at all supportive, and Jane turned to her Percocet. Michael found her in their bedroom unconscious and called 911. Jane was brought to the ER and was placed on suicide watch. So my bad, I will start it from where we left off.
I see. So you were upset. Did you wish you were dead or wish you would sleep and not wake up at all?
No, I was mostly angry at him, but I did not wish any of those things.
Okay. Have you ever had thoughts of actually killing yourself?
No, not since after my surgery, which was about 5 years ago.
Okay. And have you ever made plans about the intent to kill yourself?
No, not even when my accident happened. I'm not suicidal.
Okay, then what made you take so much Percocet?
I've been back on my pills for a couple months, and at first when I took my usual dose, it would make me feel better, but that didn't happen this time. So I took another one, and when that didn't work, I guess I just took another one until I eventually became unconscious.
Yeah, so she was in our bedroom for about 30 minutes, and I went to check on her, and when she didn't answer immediately, I panicked and I went in, and when I found her, she was barely breathing.
Okay, so your body had gotten used to the amount you had taken, so you took more, but not because you wanted to kill yourself.
That's right. My pills usually help me when I'm feeling bad, and I just wanted something to calm me down, and they usually help with that.
Okay, well, would you mind if we talk about some safety strategies to help you cope better?
Yes, please. Yes.
Well, it looks like you have good support here.
I do, probably a little bit more than I deserve.
Okay, well, I'd like to start off with a quote by Helen Keller. Although the world is full of suffering, it is full also of the overcoming of it. What does that mean to you, Jane?
That means even though I'm going through something right now, I can overcome it, and I can beat it, and I want to. It's been 5 years, and I want to get past the person I've become.
Good. It sounds like you're motivated to work on yourself.
I am.
All right, well, let's get to work then. When we're healing from substance abuse, there are 3 stages: safety, mourning, and reconnection. So safety is where you are now. Your goal is to free yourself from substance abuse, gain more self-control, learn how to cope, not hurt yourself or others, and attain sustainability. Would you agree?
Absolutely. I don't want to put myself through this again, and I for sure don't want to put Michael through this again.
Great. So what does safety mean to you? I mean, normally I'd have you write it out, but I know you're hooked up to a bunch of stuff, so it might be difficult. So you can just say it.
Safety is a peace of mind where I can take whatever is bothering me or has hurt me and get past it without turning to drugs. Michael is safety, a place where I can feel and trust everything is going to be okay.
Good. It seems like you've put a lot of fun into that.
I have. It's something I've wanted for as long as I can remember.
And how do you think you look for safety now?
I turn to my pills. They give me this false sense of safety and just mask my pain.
And do you think you're ready to learn some healthier safety tips?
Yes.
Okay, well, here we go. Let me hand you that. This is a list of safe coping skills that you can turn to when things get tough for you. So let's go over each one and see what your thoughts are. And would you read them aloud?
Yes. Okay. The first one is ask for help.
And this is something where you'd reach out to someone who you feel is safe. It sounds like Michael is that person for you, is that right?
Yes, if he'll still have me.
Always.
Is there anyone else you'd like to add?
Not really. It's just me and Michael right now.
No problem. Our safe people list can always be added to. What's next?
And inspire yourself.
And this would look like carrying something positive or negative with you as a reminder. For example, a positive thing might be a quote or an inspirational poem or something of that nature. And something negative might be a photo of someone that you know who's passed away from overdose.
Okay, could I use a picture of my horse as a positive? She's recovering well from our accident and living and enjoying her life.
If that works for you, that works for me. What's next?
Leave a bad scene.
Good. And what do you think that means?
Leave when things get bad.
Exactly. Remove yourself from any situation that would lead you to using. Now I'd like to go through the remaining options and I'd like you to pick 3 that you find helpful.
Okay. I think healing above all, saying what I really think, and creating positive addictions will be helpful.
Great. How so?
I think reminding myself that my goal is to no longer believe that I need the pills to feel better, and I want to move forward with a more trusting relationship with Michael. I've had a hard time not saying what I feel, and I just don't want to start a fight or anything like that. So if I try to say what I really think, maybe will help lessen the stress of all of that and stop the pushing down of it. And if I can put my energy into a positive addiction, it might replace the outlet that is for pills.
And what kind of positive addiction are you thinking?
Maybe strength training.
Oh.
After my accident, my leg has never been the same, and it's never completely healed, even though we have been on breaks, and I just didn't do any of the exercises my physical therapist suggested, so maybe I could work towards that.
Well, that sounds good. Just be mindful of pushing yourself too far. Even positive addictions can sometimes be too much. So I encourage you to set healthy boundaries for yourself.
Okay. Maybe instead of my exercises, I could take up a hobby.
What do you have in mind?
I've always wanted to make handmade leather harnesses for my horses, so maybe that would be cool.
Yeah, that seems like something you could easily commit to. Let's start there.
All right.
All right, so moving forward, I'd like to schedule you for an outpatient program since you're going to be discharged tomorrow.
I need all the help I can get, so.
That's what we're here for. So what questions do you have for me before I leave?
How often does she have to go to the outpatient thing?
Well, typically we start off with once a week, and then we can tailor it to her unique needs.
Is there anything else I can do to help?
Well, continue supporting her. It seems like you're Jane's main source of support, and that will be very helpful for her recovery.
Alrighty, I can do that.
Thank you. And thank you. This has been a much needed check-in. I needed to get back on track.
All right, well, keep using your skills. It's a long road, but you're capable of getting there. And we will talk next week, okay?
All right, thank you.
All right.
All right. So what'd y'all notice? What do you want to talk about? Mm-hmm. Okay, so Alyssa had just mentioned that she noticed how like the quote was from the Seeking Safety curriculum. What else? And my online people, feel free to jump in as well, either through the chat or you can just shout it out. Okay. Okay, so Chelsea pointed out that they did the suicide assessment, even though she wasn't suicidal, right? But with an overdose, we don't know. Do y'all happen to recognize what suicide assessment was used? The Columbia, yeah, the Columbia's what is it? Suicide severity rating scale. The the SSRS. Yeah, we learned about that, right? One of the first things y'all learned. What else? Billy?
I thought that the way the counselor asked the question at the beginning about the husband or significant other scene, the, I don't know that that would have been like the best way to ask that because it almost gave some pressure, I thought, for her to say yes and to stay because he was standing there and she couldn't be like, oh, no, you know. And so then as she was talking, because it was kind of
yeah.
Like Michael was my support, and then she'd be like, "Yeah, Michael and I don't really get along." And it just didn't seem
like her answers.
Yeah,
Okay.
and I wonder if that could be
Something. Okay.
anyways, if she wants him to come in, then he can come back in. Or just more space to say, especially and to make her educate herself.
Yeah. Okay. So let me translate for my online people. So Jolie was talking about how at the very beginning, whenever the counselor had come in and you know, asked if Michael or if Jane was okay with Michael staying in the room, that it may have made Jane feel pressured to do so, because it was almost like throughout the entire simulation that Jane was kind of looking to Michael for approval of her answers. And there was just some inconsistencies with, you know, Michael's my main source of support, and like we're also having problems, and that's why I self-medicated tonight, right? And so just maybe doing something, finding some kind of way to get Michael out of the room, to see maybe if, you know, Jane actually preferred him out of the room. So with that, do y'all have any ideas of how that could have been handled differently? How we could have made Jane maybe not feel so pressured to say yes?
That way.
Yeah.
It doesn't seem like remove him, has to be private and her not. And with him, her always looking at him. I probably would be like, right.
Okay.
So, you know, who else? You're fine.
Yeah.
I find that person, she's very much like
Michael. Yeah.
And then,
yeah. Yeah. So Katie was talking about, you know, maybe getting Michael to step out of the room, you know, like, hey, there's some, you know, there's some assessments that we need to go over, you know, go wait in the waiting room or whatever. And, you know, if we need you, we'll come get you, kind of thing. And then she had mentioned that she appreciated how the counselor cut Michael off whenever he started answering for Jane at the very beginning. And in the chat, Nora had mentioned that there seems like there's some unsaid hurt between the partners, like she doesn't feel totally supported by him. And yeah, and so kind of going back to what Katie had just said, right? So kind of reframing the questions, you know, once she was saying like, oh, well, Michael's my biggest source of support. Okay, well, who do you turn to when, you know, maybe you and Michael are fighting or you can't get a hold of Michael or whatever? So just kind of helping her maybe identify some more safe people. Right. So Chelsea just mentioned also putting like the therapist putting in her opinion about, you know, it's okay with me if he stays in here, if it's okay with you, that maybe taking that opinion out so that way it's not adding to the pressure of Jane, you know, wanting him to, or being okay with him staying in there. Yeah. Mm-hmm. Yeah, so Matt was saying he likes the assertive approach that Katie had suggested, right? Of, okay, well, you're gonna step out of the room, we'll get you if we need you. Because we also have to take into consideration our own safety, because we don't know the dynamic of the situation that we're walking into. And so just making sure that we're doing like literally seeking safety for everybody involved, right? Making sure that ourselves are protected as well as our patient. Yeah, so Ashley was saying that, you know, going back to what the other Ashley had said earlier about, you know, PTSD and substance use being very closely related, that, you know, maybe there's some intimate partner violence going on, and that sometimes whenever we're seeking safety, it's from, you know, not just the substance use, that it's from, you know, HIV, domestic violence, and that kind of thing. And so, you know, we don't know what goes on with our clients, you know, only what they tell us. And so, yeah, if it was a domestic violence case, you know, maybe that's why Michael was so adamant about being in the room, right? Just like with human trafficking, right? It's very hard to separate the victims from the perpetrators, because it's like, well, I don't know what you're going to say when I'm not here. And so making sure that we're giving the clients or the patients that space to maybe come forth if there's something that they need to come forth with. Anything else? Mm-hmm. Mm-hmm. So Julie was asking, you know, if maybe she's wondering if there's something else going on within the relationship, because taking medication like that, just because of an argument over him not being supportive over her new job, she said that seems a little drastic. And I didn't go that in depth in the case study, so we don't know. It could be. We could speculate, right? But yeah, there's a lot of questions that we would need to have asked before we got to this point, for sure. Yeah. Mm-hmm. Mm-hmm. Yeah. Right.
And I was like, okay, well, you come right back. Unless you fully over it, and then there isn't that.
Yeah, and so Katie was just saying that, you know, establishing safety at the very beginning, because we don't know if the client's going to be safe after they leave. So, you know, like, yes, giving her the coping skills and things like that are great. And if she's going to be returning to an unsafe environment, then chances of, you know, relapse and her ending right back in the ER bed or worse, you know, they're going to be more likely. Any last minute questions, comments, or concerns? All right. Anything else you wanted to say, Dr. I?
No. Good job with all your questions and your recommendations. And thank you all so much